Gloria, just record to the cloud. Not yet though.
So just to confirm, am I the first one to speak, or Deepa, or any of you, Gloria, are you speaking as well? Or I just welcome everybody?
Just you, Umberto.
Okay.
Hit away.
One thing here in the screen, it says that you are in a practical session, start webinar. So what should we do? Start webinar?
No, we will start the webinar.
Okay.
Hey, and listen, colleagues, when you're not speaking, please put off your camera. Just put your camera when you're speaking, or when you have the panel questions, then we can have all panelists maybe put their cameras on. Thanks.
And I will be spotlighting you, so it'll be just your video that shows up anyway.
Okay, Fanja, you can start recording.
Ready to open? Okay, I'm opening the webinar.
Hello, there is a request here to start webinar. Can I click that?
I'm starting it now. I will.
All right, cool.
Hi, everybody. Welcome to the second day of the event. We're just waiting for all participants to come in. So another minute to go, and then we'll get started with the event. Good morning, buongiorno, bonjour. Hi, Ghana. Okay, so I see many are coming in now. So we'll give another 1 minute and then we get started. Hi, everyone again. Okay, in the interest of time, I'll start. I'll open the event. My name is Umberto Baggio. I'm the Community Engagement Senior Advisor for the IFRC, and I'm welcoming you today. So I see more people coming in. I hope we will have so many more joining. It's exciting today to open the event. The event, again, just reminding everybody, this event, the Vaccines Demand global event, is about learning, exchanging, and discussing about ways to accelerate vaccines confidence and uptake among high-risk groups through investing and sustaining risk communication and community engagement approaches to reinforce local community-led systems and structures. So yesterday, I hope most of you were with us. Yesterday, we had an enriching high-level panel discussion, and we discussed how we can ensure political buy-in and commitment to investing into demand generation strategies, which meaningfully engage communities and build trust. We had global, regional, national, local leaders discussing three interconnected needs to succeed in this task. One is political leadership. The other one is greater focus and attention on the high risk and most vulnerable populations, the elderly, people with comorbidities, but also the community health workers, which need to be at the core of the approaches we are having. And last but not least, stressing the urgency, so overcoming complacency. And after this leadership panel, we had a rich technical discussion with 10 presenters. I hope some of the presenters are still with us today. And so many of you have exchanged around effective behavioral interventions and services, quality approaches that meet the people on their terms. We've learned that hesitancy is an overused term, which is often hiding several other social and behavioral determinants of low uptake. We've learned about the need to invest into last mile delivery infrastructures. There are many willing arms, like Tad said yesterday, in countries. And indeed, the intention to vaccinate is often very high, but we need to ensure that the service and information about it is accessible to everyone. We've learned from Sierra Leone to Syria to Congo to and India, and we've heard from them about the need to have a multi-pronged approach, combining community participation, co-designing messages and solutions with the communities, and bringing the service closer to where people are through events-based approaches or mobile teams, among others. We've heard about involving trusted members of communities, leveraging community systems and structures and mechanisms, and having hyper-local approaches to meet the people where they are, take the time to address their questions and acknowledge their concerns, online or offline. Last week also, we've heard in the Geneva Learning Foundation Teach to Reach event, the experiences of many of you, many immunization professionals that were with us yesterday on the front lines, people that are on the front lines. They are confronted with disinformation, hesitancy issues, and what came out of it, again, is the importance of community health workforce and taking the time to support and listen to their concerns. So today, today is going to be another exciting day. We have two sessions, two technical sessions. First one is going to be led by Angus Thompson, senior social scientist from UNICEF, and Stacy Nobler from the Sabine Vaccine Institute. We're going to talk about strategies to counter rumors and misinformation. And then we have Danielle Petty with us from the Belinda, from the Gates Foundation, sorry, Danielle, guiding us into a conversation around community engagement strategies to build trust in vaccination. The closing will be from Sylvia from the Collective Service, Risk Communication and Community Engagement Collective Service, and Deepa from UNICEF, that will then close the discussion on what's next after this event. And with no further ado, I'll pass the floor to Angus and Stacy.
Thank you, Umberta. Good morning, good afternoon, everybody. I'm really looking forward to our session today. I'd actually highlight that the title of the session is Effective Strategies to Counter Rumors and Misinformation, but also information voids and confusing health guidance. Indeed, any of the information needs of the public. I think we've all had the pleasure of a new word in our vocabularies during this pandemic, infodemic. We've certainly seen that misinformation and disinformation, deliberately produced misinformation, has been spreading, and that the social media platforms and the algorithms that they use actually can turbocharge the spread of disinformation. These algorithms that are designed to push user engagement at any cost, to get people's attention, to get them to share. But these platforms also provide us with an opportunity to engage with people in their online and, of course, their real world communities about what matters to them. So every country has been dealing with mis and disinformation while attempting to provide the accessible and relevant information that people need. This session is going to provide us with 5 really interesting examples of what might work in terms of countering misinformation, getting the information that people need to them in the form that they need, where they are, answering their questions and concerns. And a few of the presentations will also showcase not just the what, but the how of an effective national vaccine social listening program, which is coupled with RCCA and communications activities in the field. As Umberta touched upon, we heard last week at the Geneva Learning Foundation event from many immunization professionals in the field that they were constantly dealing with the disorienting effects of dis and misinformation amongst the communities, but also amongst their colleagues. And what we've seen is that disinformation can stick just about anywhere. It's not just in communities, it's amongst health workers, it's even right up to the political leadership we've seen in some countries. So it's a challenge we've always faced in immunization programs, but it is emerging as a serious challenge now. The other theme that came up in the French language sessions that I joined last week at that event was the importance of listening to people to better understand their concerns and their questions before engaging with them, and for people to be hearing from trustworthy voices. And I think these are key principles that will emerge in the following presentations. I'd like to just introduce, before I go to the speakers, my co-facilitator, Stacey Nobler, who's VP of the Vaccination Innovation and Global Immunization team at Sabin Vaccine Institute. Good morning, Stacey.
Morning, and thank you for having me.
Should be helping me in particular with the discussion, because we're now going to move fairly rapidly through the 5 talks. So we're missing one on this slide already. So can we go to the next slide, please? And I'd like to ask Joseph and Arnav to present their experience in Malawi, please. You've got 9 minutes. Handing off to you.
Wonderful. Thank you very much, and thank you all for having us. We'll be presenting with Joseph Mwase about our project that we did as partnership of myself with Kati Kati, a social venture, and the Malawi Red Cross. And so with that, I'll just allow Joseph perhaps to introduce himself and take us through the next slide.
Hello, everyone. My name is Joseph Mwase. I'm the team lead for Help Desk here at Malawi Red Cross Society. The Help Desk is more of a feedback and complex mechanism, as well as rumor tracking and management. So I will start a presentation whereby we are implementing a project of mass SMS receiving and sending to manage rumors and feedback. So what really triggered us to start this initiative? There was explosion of rumors. So we needed close contact with the volunteers, crucial to address this. In Malawi, there is unprecedented increase in the volume of rumors, misinformation during the COVID-19 pandemic, which contributed to low vaccine uptake. So with those rumors, people were afraid to take the vaccine. So Malawi Red Cross Society realized the need to be closer to its volunteers working at the front line in their respective communities by providing them with updated information on COVID-19. So with this problem, there was need for a remote, trusted, and the dynamic channel of communication to better inform volunteers and communities on the same. Malawi Red Cross Society realized that that if each volunteer do not have a dynamic channel to raise their questions and comments in real time, you are not able to successfully provide the information that the communities wish to know to better inform their decision on vaccination against COVID-19. The help desk was accessible or is accessible to volunteers by email, WhatsApp groups, and toll-free number for calls. The help desk typically was used to receive 20 calls a week and 15 calls by WhatsApp. So the team wanted to increase their volunteer feedback and participation, as well as encourage behavior change for COVID-19 vaccine uptake. To do so, the National Society piloted the project with Katikati, a web-based platform which allowed MRCS to handle many one-to-one digital conversation in Chichewa and English with their volunteers on a toll-free and accessible two-way SMS shortcode. Over to you, Arnav.
Great, thank you, Joseph. And so my name is Arnav Kapoor. I work at Katikati, and we are a social venture that provides software to organizations across the world who want to hold meaningful, impactful remote SMS communication with their communities, their citizens or employees. And so with Joseph and his team, we were providing the software, the training and the support, but it was his team and it was the Malawi Red Cross that were speaking to their volunteers. And so what we did here is what we worked with Malawi to do is set up a two-way SMS channel where volunteers could text in from across Malawi and also have an ability to use a toll-free shortcode so that it was accessible and affordable for individuals to reach it. They were also thinking about one of the things we heard yesterday as well was this notion of what does it mean to listen to individuals? And if you do that, what space does that create in their response and their reception to vaccine or public health information? And so at Katikati, what we've thought a lot about is we've seen a lot of chatbots and automated surveys enter the space of public health information. And with the Malawi Red Cross, we were thinking about, well, what does it mean to keep it human-led? And so Joseph and his team will explain how he was handling those messages. But in that human space, allow for richer conversations, and in so doing, hopefully better access and better receptivity to some of these ideas. So on the next slide, what you can see here is this is a Katikati interface. And this was the one that was relevant to the Malawi Red Cross. And so in the middle section, what Joseph was doing is, so he was sending messages in Chichewa. We have an automatic translation. So there's an English line, which is not always 100% accurate, but gives you a feel. So Joseph and his team were asking 1,000 volunteers, we'd like to know what are the problems you face in your work and what are the rumors around COVID-19 vaccines. And so this individual, we anonymized the data to protect identity, was responding and mentioning that here they were saying some people are making fun of us by telling us the vaccine is bad and COVID is, etc. And there are a few things happening that Joseph's team were doing a great job here. Is one, they were responding to the individual with a message that they could create prior and standard message they could help send. So they were responding to this concern about the vaccine to this individual to help with their issue. But secondly, you can see that they were tagging. And this is where we focused on two elements of tagging. So the red one, it says escalate. And so Joseph's team were tagging this message as escalate to make sure it gets treated quicker by the team and focused on and tracked so that tomorrow they can make sure anyone who had an escalated issue got the response or got a follow-up. The other element is they were creating tags that you can do in Katikati quite easily to mark that, in this case, different myths that were coming up around COVID-19. So this was here, COVID-19 is not real. And so Joseph was adding this tag to this message. Sometimes he was creating new tags because of a new message that came in. And in so doing, he's having a conversation with an individual, responding to their concern, providing the information that they need that is suited to them, as well as gaining insight across conversations. And we'll show you a dashboard that Joseph will walk through and how that happens live. But I think this is what we were really excited about, is keeping it human-led, but through that, hopefully promote the right information and get people's concerns answered. So Joseph will now take us through the next slide and his experience of it.
Thank you very much, Anna. Thanks for that well-explained presentation on slide 2. Slide 3, please. Thank you. So what are the results, insights, and what volunteers appreciated during our time of implementation for Katikati? So MRCS, with the help of this platform, was able to offer an open, accessible, and remote channel for volunteers to share their feedback. As I said, this is a platform whereby volunteers are able to share the feedback, and it's also more anonymous. It doesn't really display their names, so volunteers are able to share whatever feedback they have without fearing, of any consequences. And this platform was able to identify, address sensitive complaints, and rumors quickly. As Anna has mentioned earlier, that if we saw that there was an issue that needed a quick attention, we would tag it as so that it can be addressed quickly. So this platform has really helped to do that, and we were able to hold one-to-one conversation with over 1,000 volunteers with a small team. So basically, in the help desk, we are 3 of us, and we are able to manage all the feedback that come through the Katikati. Yes, and another one is that it encourages the volunteer participation, to ask questions and gain insight from them in real time. So these messages come in real time, and we are also able to respond in real time. So it gives that appreciation to the volunteers to say that, well, okay, it means that help desk for Red Cross is really appreciating us to give us feedback in real time. So what are the key learnings? The key learnings for this project is that volunteers play a key role in reaching inaccessible and marginalized populations. As you know, Red Cross over relies on the volunteers to implement its activities. So other communities are in a very marginalized location, and these volunteers help us to reach to these marginalized as well as inaccessible populations. And through the Katikati, the volunteers are able to bring out those issues, those feedback from the communities, and to bring them forward to us through Katikati. And leveraging the trust that communities have in Red Cross and combining it with the digital solutions provided by Katikati has allowed a small team to handle conversations with hundreds of volunteers. MRCS is utilizing this data to address feedback and provide support targeting COVID-19 vaccine uptake. Rumors are integrated into volunteer briefings to equip them with information to engage communities in fact-based dialogue. The aim is for you to help the audience rapidly understand the problem you address, the solution, how you measured the impact, and the most important key learnings which will help them successfully apply the same approach in another context. The focus is for the help desk to reach the volunteers so that the volunteers are able to give us feedback, which they are not able to respond to the communities, as the communities are maybe bringing the questions to them, and some volunteers do not have that capacity to able to respond. So the Katikati platform is there for the volunteers to reach out to us for those issues, and us at the help desk using this platform to be able to respond to them with correct information, and that increase the demand for the vaccine, as well as reducing the trend of rumors, as well as other misinformation on COVID-19, as well as the vaccine. Thank you so much, Anna.
Thank you so much, Joseph. And I'll just perhaps quickly add, if we can return back to that previous
30 seconds.
slide. what you can see in the
30
top
seconds,
right.
you're already over.
Oh, 30 seconds over.
No, you're more than 30 seconds over. You've got 30 seconds.
I see. Okay, thank you. In this top right, you can see rumors and misinformation. So in the tagging that Joseph was doing in Katikati, that was creating in real time this analysis, which Joseph mentioned they used to then direct some of their training for volunteers. So this all happens in the same space. Thank you all for the time. If anyone's interested in Katikati, please reach out. I'll drop my name and contact.
Thanks, Anna. Thanks, Joseph. That was really fascinating. Let's jump to the next one straight away. We'll have time to discuss at the end of the 5 presentations. I'd like to ask Anastasia Nuzinska and Hamid Kashan to present on the work that they've been doing in Ghana, please. Hi, Anna. Hi, Kashan. You've got 9 minutes.
Okay. Hi, everyone. Welcome and thank you for giving us the platform. Now, closing the loop on digital media, in this particular presentation, we're going to explore how digital media could lead to verifiable and measurable impact that we can connect to our SBC priorities. In this case, we had a great partner with UNICEF Ghana to work with, and to start us off, I'd request Anastasia to take us through the first slide. Next slide, please.
Colleagues, good morning. So Ghana was lucky and unlucky at the same time, receiving COVID vaccination as the first country in the world as part of COVAX facility. So it actually influenced us in a way that we faced much more rumors than maybe any other country, because there was a question, why Ghana? You know, is it like conspiracy with of the senior management of the country? Is it some testing, etc.? So the amount of rumors was enormous, and it was a fueling country inside and outside. And another 2 phenomena that we saw that actually made us think about actually what Kashan said, closing the loop, is how online rumors quickly fuel offline and vice versa, as well as how polio vaccination campaign can affect COVID vaccination campaign, and again, vice versa. And that was a huge problem, because we had actually 2 ongoing campaigns, and quickly reacting and actually trying to mitigate the risks from new COVID vaccination campaign in order actually to ensure that polio ongoing vaccination efforts are also maintained was extremely important. So for us, digital intervention was extremely priority. And the third reason would be also family members. Through all our research, we saw that family members would play one of the most important roles in affecting the decision to get vaccinated. So affecting and trying to build the campaign digitally would make the younger population be more confident about vaccination and influence other members of the society, which sometimes is very extremely difficult to reach. So over to you, Kashan, to explain the case itself.
Thank you. So as Anastasia mentioned, that vaccination programs are intrinsically linked. We've seen country after country that hesitation towards one vaccine affects hesitancy towards others. And Ghana was at risk of polio because there was a lot of neighboring countries that had active circulation. So we needed to make sure that if and when we needed to go into Ghana for a vaccination campaign, there would be widespread support for vaccination, and we would be able to navigate the vaccine hesitancy we noticed during the COVID-19 lockdowns. Next slide, please. So to work around this challenge, UNICEF created a polio digital community engagement unit out of New York. The goal of the unit was to provide hands-on support to countries who don't often have the amount of personnel or are overburdened with a lot of work, or simply just don't have the capacity to work in digital spheres. So it started as an internal startup in 2021, and we partnered with 5 countries. Ghana was one of them. In Ghana, we found a very willing and very collaborative partner, which was willing to try out new strategies and new approaches to address this challenge. We started with a misinformation management workshop. This workshop led to the creation of a misinformation task force under the Ministry of Health. On this task force, there were all partners, WHO, Ministry of Health, and other partners who are relevant to the conversation. Under this body's supervision, we created UNICEF Ghana's online social listening infrastructure. We had analysts who were looking at information streams that were coming out and identifying information gaps that were expressed by the community or expressed any misinformation that needed to be addressed. Analysts shared this information with the task force, which then decided which information or which misinformation needed to be addressed, or people were in need of more information from our side. Based on this social listening, we created SPC-approved messaging. This messaging was A/B tested before it went out. Some of the images that you see in front of you are examples of this. These designs are under the same branding that Ghana was already using. It was important to use the same branding structure so people have immediate recognition when they see this branding online and when they see it offline in their communities. This creates higher confidence, and this was proven by our A/B testing. Next, once we had the SPC-approved messaging, we deployed it on Google and Facebook through paid advertising and in a geo-targeted campaign that was focused on Ghana. We were particularly targeting 18 to 45-year-olds because our research showed and our online social listening results showed that these were the people who were most engaged with COVID-related conversations and were also were the ones who were raising the most questions. So this campaign was specifically trying to reach them. On the measurement side, we used established tools such as Facebook Business Suite and Google Analytics to measure the impact of the campaign. The campaign reached around 6 million people through social media channels in Ghana, and it directed around 250,000 people to Ghana Country Office's FAQ page on COVID-19. Next slide, please. So once we did all of that, we needed to close the loop because too often our vaccine communication goes out onto social media and we think our job is done, but we need to demonstrate that the impact can be measured and should be connected to our SPC priorities. In this case, we conducted brand leaf studies and online surveys through multiple audiences in Ghana. So we had a control audience and we had an exposed audience, and in these audiences, we were able to demonstrate significant impact between control and treatment audiences. We showed 7% increase in recommendation of the vaccine to friends and family. We showed 4.3% increase in belief that vaccines are the best way to protect against COVID-19. And similarly, 4.2% increase in trust that vaccines are better than natural alternatives. Now, these questions and these narratives were arrived from our online social listening. So in addition to this, we created U-Influence, which is a global volunteer social media influencer network who are willing to communicate with their communities and support vaccination conversations. This was a great example of how international partnerships can deliver great results at the local level. But some of the key learnings that we identified, I think Anastasia would be much better suited to tell us about them. Anastasia, over to you, please.
Thanks, Kashan. So on the key learnings, the interesting thing, as Kashan said, how we use the existing branding in this campaign. Good Life brand is a brand that was created by Ministry of Health, Ghana Health Service, but it's not actually institutional brand. It's a brand that informs people about health and well-being. And for us, in the territory where we were still not certain who would be the most trusted source of information, using the brand that actually appeals to people without any kind of brand or institution behind this, not branded by UNICEF or any other organization, was extremely important. And the brand is recognized. And again, it's advertisement in, as we understand in reality, but packed as actually a health information. So localizing design was extremely important. Having support of misinformation task force, which I consider as one of the biggest results of my work, Kashan, polio team and other all involved agencies, is something that will serve not only COVID, will serve also all other campaigns. Now we have yellow outbreak and so many other issues related to misinformation. So this is actually a great example of how partnership, cooperation, and support and flexible support will help all other campaigns, despite, you know, it was support from polio team, but actually to COVID campaign, but actually it will serve all of us because the vaccine hesitancy can affect all other campaigns. And of course, A/B testing is essentially important because it will not be relevant to the audience. The influencers that we build, we will use, and we are already using them in our other work. And we're working now on researching how actually the misinformation is spread among influencers and journalists, and that's something what we are really looking forward to see the results of. So overall, to have the digital campaign is something that now you cannot avoid, even if you think that hesitant population is only around rural areas where there is no online rumors, because we saw the issues when one person in the village holding the phone and showing the rumor or this, specifically exciting video with misinformation to all other members in the community. So I think for us, it was a really great partnership and good case. Thank you.
Thank you, Anna. Thank you, Hamid. Spot on time. Well done. We'll maybe calling you back for the discussion. Let's jump to the next speaker straight away. Joré Larsen Nana is going to describe work that's been done in Côte d'Ivoire. Joré, are you there?
I'm here.
You've got 9 minutes.
Great, thank you so much. Good morning, good afternoon, everyone. I'm Joré Larsen Nana. I'm with the Johns Hopkins Center for Communication Programs, and I support the Breakthrough Action Global Project, which is funded by USAID. And I'm really pleased to be here this morning to talk a little bit about our work in Côte d'Ivoire, utilizing our dynamic listening and rumor management system data to develop adaptive communication and RCCE strategies around the COVID-19 vaccination campaign. Slide. So to provide a little bit of context and frame the challenge, since March of 2021, Côte d'Ivoire has been offering vaccines to its citizens, first to priority groups, and then a few months later, they began offering it to the general population. And from the very beginning, it was evident that progress towards the World Health Organization target of 70% vaccination coverage has been very slow. We conducted a knowledge, attitude, and practice survey in mid-2021, which was the first of several rounds of surveys that are being conducted in Abidjan. And this suggested that there were multiple reasons that Ivorians had low vaccine confidence, from fear of the vaccine's presumed effects on fertility to lingering low risk perception attributed to COVID-19 disease and low perceived vulnerability to the severe consequences of the disease. So in the context of the slow progress of the vaccination uptake and the evidence rumors and misinformation, the main challenge for Côte d'Ivoire's RCCE stakeholders is how to not only have access to information that is timely, focused, and readily available on public sentiments and rumors, and also how they can use this information and really incorporate it into a process of adaptive messaging that addresses those concerns as in real time. And this is particularly important during times where we know that the risk of COVID-19 transmission will be particularly high. Slide. So Breakthrough Action, as I mentioned, had conducted several rounds of CAP surveys, which provide us some level of information about what people are thinking and feeling. However, a main source of our adaptive messaging has been our rumor management system. And this rumor management system was established by Breakthrough Action with the National Risk Communication Technical Working Group, actually pre-pandemic, to respond to any sort of epidemic or emerging disease threat. And our rumor management system currently has 3 main channels. The first channel is our network of community-based key informants who are trained to recognize rumors that they may hear in the community and to share those rumors by an easy WhatsApp channel that feeds into a rumor database. Secondly, we use the National Public Health Hotline. We have a partnership with the hotline, and the operators have been trained to recognize rumors that are coming in from incoming calls to the hotline. And these are later synthesized, coded for themes, and constitute part of our rumor analysis process. And finally, and most recently, we have added a social media and social listening component to the rumor management system. We utilize the Meltwater package to regularly scan the social media environment of Côte d'Ivoire, the most common social media platforms, and to assess trends and emerging themes and perceptions that are coming from these channels. And so these 3 channels together constitute a database which on a monthly basis we review with the Risk Communication Technical Working Group synthesized into a set of succinct briefs for stakeholders. You can see an example of the brief on the right on the bottom there. These are intended to be, short, concise documents that are shared widely, that give a quick overview of the tendencies, the themes, and the trends of rumors coming out of these channels, and then offer some communication-related recommendations based on that information. So these are the briefs that are produced and disseminated. And just to highlight a couple of ways that Breakthrough Action has been able to use this information in our own planning and support to the government around communications efforts. Number one, journalist training. When we train journalists, we use the rumor management system information in order to really highlight those themes that are most prevalent in the population, so that journalists are able to accurately and understandably address that specific rumors and misinformation in their media coverage. Secondly, we developed an intensive national radio campaign beginning in mid-December of 2021 up through the end of December, up to the New Year's holiday, which in Côte d'Ivoire is a major time for population transit, festivals, etc. And this campaign, really, the messaging was aimed at addressing the specific misinformation that we saw coming from the rumor management system and encouraging continued prevention behaviors, because another theme that we have seen emerge is that people are less interested or willing to continue practicing other prevention behaviors regardless of their vaccination status. So we aim to address that with specific and focused messaging during this campaign. And finally, we created a series of television spots that respond to prevalent public concerns that have come out of that rumor management system, including and specifically the fear of side effects and adverse consequences of the vaccine. In terms of how we look at the success of this effort, we measure it based on the total number of people that are getting vaccinated and whether the coverage rate is increasing. So we monitor regularly the Ministry of Health statistics regarding population level coverage of the vaccine campaign, and we use that as our main measure of ultimate success. Slide. So this is just a graph to give a brief overview of some of the things that the analyses that come out of our rumor management system and what the dashboard that we have is able to show. This is an example of a graph of rumors that we have received in the rumor management system from June of 2021 to May of 2022. And you can see the different colored lines represent different main categories or themes of rumors. That orange line is related to side effects. And you can see in August of 2021, there was a huge spike in the number of rumors that were received regarding side effects. And that was one of the impetus for us to consider how can we more intensively focus on that issue in our SPC efforts in the coming months. And so this is just to show you that there are many ways that the information from the rumor management system is able to be immediately used to drive communication strategies. Next slide. In terms of outcomes, this is very much an ongoing effort. We continue to support the government of Côte d'Ivoire in this very intensive phase of the campaign that is currently going on. But just to provide a snapshot of this period at the end of December, late in 2021, where we conducted this intensive communication campaign, we were monitoring coverage of the vaccine. And prior to the campaign, 22% of the eligible vaccination or eligible population was vaccinated with at least one dose. Following this campaign, the number rose to 36%. In terms of full vaccination, it rose from 10% before the campaign to 15% following. And then amongst priority groups such as health workers, the military, and the elderly, by the end of the campaign period, overall coverage with at least one dose was very high. We continue to measure the impact of these efforts through regular monitoring of vaccination coverage with the Ministry of Health, particularly as the Ministry of Health moves towards vaccinating new groups, most recently adolescents aged 12 to 17. And we continue to see that the rumor management system data has an important role to play in developing and rolling out that adaptive messaging across communication partners. In terms of key learnings, I can just highlight a few key things. The first is that these rumor management systems and iterative feedback processes are really critical to giving stakeholders the information that they need in order to adjust messaging. But as much attention is paid to generating the data and synthesizing it and producing a succinct document that summarizes it all, it is very important that the data that is generated forms the basis of a national conversation and feeds back into the risk communication and community engagement action plans, both of individual partners, but as well as at a national strategy level, which is why we prioritize and consider very important our collaboration with the Risk Communication Technical Working Group and the regular discussions with the group and the members of this group around the data so that all partners are able to use the information to their advantage in their communications efforts. Additionally, we found that the RCCE strategies that are focused around high traffic holiday periods to address misinformation and rumors have achieved good results. We replicated the experience of the New Year's campaign successfully around Easter in Côte d'Ivoire, another major festive holiday, and found that there were significantly positive effects around that as well. And finally, mass media and community engagement approaches are equally important in curbing rumors and misinformation. So we found that mass media is great for reaching the broad public and having high visibility to address the most common concerns, side effects, addressing COVID-19 risk perception, et cetera. But this is really most effective when it's coupled with a more direct, focused community engagement approach involving strategic leaders within specific subgroups who can address the concerns and the rumors within those groups. And with that, I'll conclude. I look forward to your questions.
Thank you, Jory. And in terms of questions, folks, please put your questions in the Q&A, not in the chat. And I'd also ask the presenters to just track the Q&A. And if there are any very specific questions, you can respond to them directly. You can answer them directly. Leave the more general questions there and we may come to them in the discussion. Just a couple of other housekeeping things. We should have warned you, we should have given you a heads up front. There's simultaneous translation in Arabic et en français. You have a button down the bottom of your screen in Zoom called interpretation. You can choose your channel there. And please don't raise your hands. We won't be able to respond to questions like that. If you have a question, put it in the Q&A. If you have a nice comment, put it in the chat. All compliments accepted. So now I'd like to go to our fourth speaker, Zap Nguyen from Vietnam. Zap, are you there?
Yes, hello everyone, I'm here. Can you?
Over to you. 9 minutes.
Yes. Hello, so Zap Nguyen, a communication consultant at UNICEF Vietnam. And I'm very pleased today to share with you about how we and our national partner, Ministry of Health, are hearing people's concern and social media on social media and addressing it with the support of the Vaccination Demand Observatory Program. So this program is a three-side cooperation between UNICEF headquarters, Public Good Projects, and the Yale Institute for Global Health. So let's start up with the problem. Next slide, please. In around May 2021, the COVID-19 vaccines started arriving in Vietnam, and there was a high level of concern about serious reaction of the vaccine. In a survey with the participation of more than 38,000 people that we conducted then, 44% are moderately and highly concerned about COVID-19 vaccines serious reactions. And in early 2022, Vietnam, like many other countries, was witnessing a rapid increase in the number of COVID-19 cases. According to our rapid survey then, 15% of respondents believe that COVID-19 is unsafe, with concern including adverse effects and long-term impacts on health, and 13% of respondents believe the vaccine is ineffective. So while Vietnam is among countries with the highest COVID-19 vaccine coverage rate, with right now is more than 95% of the population above 12 years old have been fully vaccinated with 2 doses. There is currently a slow COVID-19 vaccination progress for children from 5 to under 12 years old, and for the booster doses for adults. Vaccine hesitancy fueled in part by misinformation and information gaps continues to threaten vaccination efforts. So what's the solution to the problems? Next slide, please. So Vietnam Country Office is a part of the video of Vaccination Demand Observatory Program, which equips countries with customized social listening programs to boost vaccine demand and address misinformation. The Vaccination Demand Observatory monitors local language online public conversation, identifies vaccine misinformation within the country, and provides resources such as vetted messages and creative social media assets. And the Vaccination Demand Observatory has been working one-on-one with staff to build misinformation management capacity in Vietnam, in UNICEF Vietnam, through trainings and technical assistance. And as a partner to the Ministry of Health and also WHO Vietnam, the UNICEF Vietnam is able to apply this growing expertise to national efforts. And we are collaborating with the Ministry of Health in a 3-year work plan on COVID-19 vaccination from 2021 to 2023. And in that, we have the Safe Journeys media campaign, a joint one between UNICEF Vietnam, WHO Vietnam, and the Ministry of Health, which includes a focus on debunking myths about COVID-19 vaccine. And the program, social media listening program, is being used to refine campaign materials to ensure that the campaign is responsive to current information gaps and misinformation. And the Vaccination Demand Observatory also provides rapid response, risk communication, and community engagement technical assistance. For example, recently when a high-profile influencers with more than 300,000 followers on Facebook, she supports the Safe Journeys media campaign, and she faced a barrage of anti-vax comments on a post about COVID-19 vaccination for children. And the Vaccination Demand Observatory analysts provided consultation within a few hours about how to respond and how to answer questions and when to block and when to report. So next slide, please. What is the measurement so far? At the present, the Vaccination Demand Observatory has access to more public media data than any other public sector media monitoring program. Since its launch in Vietnam in January 2021, the Vaccination Demand Observatory has analyzed 1.3 million social listening results in the country, including 800,000 references to misinformation. And there have been nearly 50 misinformation alerts, including context, fact-checking, and suggested responses that have been provided to Vietnam so far. And this support informs national efforts such as the Safe Journeys campaign. And the what are the outcomes and impacts? The Safe Journeys campaign reached 25 million people in the first phase of the campaign, which runs from March to May 2022. And since its launch, the Vaccination Demand Observatory has supported social listening programs in 13 countries and is rapidly scaling up. And this is the using of social media listening is an unprecedented way of campaigning in UNICEF Vietnam. Before that, we had not used digital social listening to inform a vaccination media campaign like Safe Journeys. Media campaigns on routine immunization previously only utilized rapid assessment to provide evidence for campaign development and implementations. So here come the 5 key learnings here that we have after we joined the program since early this year. Firstly, integrating with ongoing national efforts to address misinformation is more effective than standalone interventions. Secondly, dashboards alone are not enough because human analysis, insights, and consultation provide tangible value. And this approach is resource intensive, but as social listening becomes a part of public health function, this approach becomes more necessary. Thirdly, more support is needed to equip UNICEF teams to respond to misinformation and support national partners. Vaccine demand efforts require receive a small percentage of total funds for immunization. And fourthly, the need close collaboration with country staff is essential to making sure the vaccination demand observatory program is responsive to country needs and useful in real world context. Fifth, the local and ethnic minority language social listening is needed to understand online conversation among ethnic minority groups. And last but not least, in addition to misinformation alerts on a weekly basis, there is also need for alerts on a real-time spike for a quick response. Thank you for listening, and I hope to answer your more questions in Q&A section.
Thank you so much, Zap. That was great. So we're going to keep up the pace. One presentation to go, and then we can have some time to discuss. We're going to keep heading east to Fiji. And Kshitij, are you there?
Yes, very much. Thank you.
Over to you. Please put your camera on. We'd like to see you as well as hear you. And you've got 9 minutes.
Great. Thanks, Angus. And hello and bula to everybody. As Angus mentioned, we are traveling eastwards. Just to give you a context, by the time I finish this presentation, I would have already entered June 24th. So we are as close to the international deadline as you can imagine. To a brief context in terms of the situation in Fiji so that we can relate to the rest of the presentation. In 2020, while the rest of the world was grappling with COVID-19 cases, wave 1, wave 2, Fiji only had 1 case. And the Fiji border control mechanisms were very strong. The government had closed the international borders. A country that thrives on tourism had closed itself literally to all flights, all travelers, except for the few border cases, largely emerging out of quarantine facilities from returning citizens or essential travelers who were exclusively allowed by the country. And in that context, we entered 2021, where we would start to roll out COVID-19 vaccination. Go to the next slide, please. So early on from COVID-19 response, a joint RCC working group was established, comprising of members from UNICEF, WHO, led by the governments in the Pacific. So we had a regional RCC working group, which is co-led by UNICEF and WHO, which provides support to all the Pacific Island countries. But in each of the countries, we have dedicated national RCC working group. And within those working groups, we had established various subcommittees. So when Fiji launched its vaccination campaign in March 2021, we were all excited, all geared up for the vaccine rollout, especially given the high demand that we had anticipated through the various polls that we had conducted prior to the launch of the vaccine in the country. Little did we expect that in a month's time, Fiji would start reporting community transmission. And it spread really fast across the country. So we were faced with double whammy at that point in time. So while we were launching COVID-19 vaccination, lockdowns were imposed across the country, and we were vaccinating eligible populations at the same time. But this also led to a quick shift in the strategy by the government, going beyond the priority population and opening up the vaccination space for all eligible adults over the age of 18. So a lot of shift required in terms of how the RCC working group overall was providing support to the government, how the communities were mobilized, not just for vaccine demand, but also to continue the NPI behaviors, especially around hand washing, wearing of masks, which was introduced much later in Fiji than other countries, and of course, the physical distance. What we also identified was while we saw a great turnout for COVID vaccines in the general space, the specific groups that we were prioritizing, people over the age of 60 years, were not, and people living with disability, were not really coming forward. And so we tried to really find out what the issues were. And likewise, at the peak of the outbreak in the country, as we're rolling out vaccines to the outer islands, we found misconception and misinformation on vaccination for pregnant women around these communities. So there's a lot of simultaneous RCC messaging going around, and the way the whole RCC working group got together. So we were meeting almost on a daily basis, all the partners, and how the group was organized is what we would like to share here. The next slide, please. So to further understand the key challenges and how things were emerging in Fiji, we established a social listening subgroup under the multi-partner RCC working group that I just mentioned. So under the leadership of the government, UNICEF, WHO, the National Red Cross Society, the Pacific group, all got together and kind of explored the options of how each one of them can contribute on the social listening aspect of the program. What was unique about the social listening initiative in Fiji was the triangulation of online and offline sources. So while, like we have seen in other presentations, we continue to use a lot of technology, especially in terms of tracking of conversations on social media using Talkwalker, which was initiated by UNICEF, Meltwater portal, news portal monitoring which was coordinated by WHO. We also had the National 158 hotline. So on a daily basis, a detailed analysis was conducted of all the calls that were made. The calls were classified in terms of the kind of queries that people would come in and the kind of feedback that people were providing. So there were two sets of groups in terms of the analysis that we were doing on the 158 hotline calls. One was in terms of the questions asked by community members on COVID outbreak, the disease, the vaccines, and then more specifically in terms of specific questions around service, where people can get. But the vaccines are which are the age groups that are being prioritized, if there were specific locations where vaccines were being made available on a particular given day. Now, along with this, the government launched what was called as a whole of government initiative, wherein the national leadership and the emergency management team mobilized various line ministries, and each one of them were given different areas to focus on. So in close collaboration with the Ministry of Youth, we started collecting community feedback. Primarily, these volunteers would go out, got exceptional permission despite the lockdown mechanisms in the country. These volunteers were allowed to step out in the community, of course, with all the protective measures for them and for the community members to interact and mobilize communities. But more importantly, they gathered feedback in an offline conversation. So maintaining physical distance, they would interact with family members, gather feedback from them, not just on COVID-related aspects, because by that time, the government had initiated a lot of other measures, especially with the schools being locked. There was a lot of push for online learning. Worksheets were being made available for students to study at home. Radio programs were happening. So a consolidated feedback mechanism was established by the RCC working group, which was reviewed by all the partners on a daily basis. So every day, the partners would bring in the feedback from their respective platforms, channels, gather the key issues, identify and give guidance in terms of follow-up and action points for the incident management team, which was basically the COVID-19 command center established by the government. So one representative from the RCC working group would go into these daily meetings at the IMT and make a detailed presentation on the key issues being flagged by the community members, key concerns, and what is expected from various pillars. So across the board, so the various pillars in terms of be it feedback on testing, be it feedback in terms of how the operations are being rolled out, feedback on the quality experience, the trust in the government was transparently shared with the IMT members, and the feedback incorporated as part of. So as a group, we kind of established measurements or indicators for ourselves in terms of how would we really measure all the efforts that we are putting into social listening. So some of the indicators that we're closely looking at was like, are the operational strategies being changed based on the feedback that we are providing to the IMT? Are the concerns which we are raising being addressed by the Principal Secretary in his daily address to the nation? The picture that you see here is Dr. Fong, Dr. James Fong. I would call him, he's the face of COVID-19 response, and he's Permanent Secretary Health in the Ministry of Health here, and he became the face. He's the star of the COVID response in the country, and one of the most trusted voices when it came to on COVID-19. In all surveys, offline, online, qualitative or quantitative, that we have conducted, the daily briefings that he conducted on national television, which was broadcast live on national television, Facebook, and radio, were the most sought after media item on that particular day. And on a daily basis, we would give him key messages that we would want to address in his daily briefing. If we were seeing a dip in preventive behaviors, he would highlight that as part of his address to the nation. And likewise, any other concerns that the community members would have raised in terms of their experience with the vaccination team, he would go out and reassure populations in terms of that they will look into the feedback that is being provided on a day-to-day basis. Most importantly, the whole indicator that we took up was if the feedback that we're getting in terms of the apprehension by the pregnant women in terms of the uptake of vaccines or the demand for vaccines, and how we can really facilitate the vaccine uptake for the elderly and people living with disability. Next one. So based on the feedback, the major structural changes were done. So apart from the regular outreach sites and locations where COVID-19 vaccines were available, the government also decided to kind of initiate a special drive through routine ANC services. So at each routine ANC services, COVID-19 vaccines were made available. Fiji has a very high ANC service uptake, and that stayed through during the outbreak and while we were launching the vaccines. So we saw that as an opportunity to kind of really reach out to this very specific target group, address their key concerns, and mobilize them to vaccinate. Likewise, a key initiative to kind of really facilitate access by the elderly was drive-through vaccinations. So, and drive-through vaccinations became a big rage. These were open all days, including weekends and Sundays. So people would just bring in members of their families in their personal vehicles or private vehicles or public vehicles, would just pass through, and the vaccination team would ensure that people have access to. Apart from this, when the community mobilizers went into the community, they would gather feedback of houses which have elderly people and who have not yet been vaccinated. This especially worked in informal settlements and places, and subsequently vaccination teams would be sent to those specific households to vaccinate. So the rule was quite straight in terms of that this is not a house-to-house vaccination initiative. The house-to-house vaccination facility was only limited to people over age of 60 years, or people with other comorbidities.
Jitesh, one more minute, please.
Sure.
We need to get to the discussion. Thanks.
Right. And in terms of the success, as you see, in a span of 1 year, we've been able to vaccinate more than 95% of people over the age of 18. Key learnings in terms of that, we're looking at social listening beyond the regular misinformation, but really how to guide operational strategies as well. And the whole monitoring, analyzing, and triangulation of offline as well as online information sources really brought about a big change in terms of how the response was, how the response panned out in Fiji. And most importantly, the timely and transparent interventions by the most trusted source, in our case, Dr. James Wong, made a big difference. Thank you.
Thank you very much. That was great. Let's jump straight to the discussion. Again, questions in the Q&A, not in the chat, please. In particular, more general questions for the panelists. Some of the panelists have been answering your more specific questions. Stacey, are you there? would you like to kick off the discussion for us?
I am here. Thank you. First, an enormous thank you to all of the presenters. They were fantastic, and I think show the incredible space, the incredible advancement in this space over a very short period of time. For me, one of the key takeaways continues to sort of emphasize the consequences of misinformation and information gaps and how quickly they really move from that online space to the offline space. All of the presenters sort of emphasize the importance of addressing these concerns in real time and how to importantly translate that so that you can adapt messaging from both mass media as well as to address general concerns, but also really how to get to that community level and the individual direct messaging. Some of the questions that we see that really emerge from this become how to best identify the selection of the right influencers, the right messengers. That's been consistent in some of the chat, and I think it's a really important issue. And then related to that, sort of training and equipping these messengers. How do you do that? So if perhaps each of the presenters could sort of get to those two issues, moving to how to best identify and select these influencers and messengers, and then critically how to train and equip them to support key messaging. And I think maybe we'll just go in the order of the presentations if possible.
So another Joseph?
Yeah, I think Joseph would be best placed to pick up on that from his experience. I think the only thing to add from my side would be the ability to build and have an open space for communication to ensure you kind of continue to access your individual influencers and messengers. I think is something that's proven to be very important, particularly when we saw with volunteers who were speaking to their communities had individual different issues and concerns. And so making sure you can address them, but also support them with the latest up-to-date information, that seemed quite useful. And Joseph, perhaps you can pick up there.
Yeah, sure. Thank you so much, Anna. Thank you so much, Stacey, for the question. Actually, on the selection of influential people to pass on the message to their communities, in our national society, which is Malawi Red Cross Society, we have been engaging community or local leaders, faith-based leaders, as well as the religious leaders. As you know, Malawi most of the population live in rural communities, and these rural communities, they rely or they trust so much the religious leaders, local leaders, as well as other leaders that are based there. Unlike those that are implementing the programs in the community. So Malawi Red Cross Society mostly relies on those leaders, and they engage these leaders in various ways. For example, community engagement meetings, or through Katikati. Some of these leaders are on the Katikati platform, which is a messaging platform. They pass these messages, and the leaders take these messages to the communities that they are serving. So that's one way how we select leaders. So it is mostly based on the local context. Like, for example, communities, who do they trust? So it is based on trust from the communities and the leaders that are based in those communities, because mostly they take us as strangers. When I say us, I mean as program implementers or project implementers, but mostly they trust the leaders that are staying in those communities. So we engage those leaders to pass on the messages so that we can boost the vaccine uptake. Thank you. Or manage the rumors that are going on in the communities. Thank you.
Okay, I think if I can add something to that as well, I think in addition to what my other panelists have said, it is very, very important that we understand that rumors have a theory. what we call the rumor theory. And rumors have a root from where they stem from. And most communicators at times ignore that fact. And those are the roots that are deep down into the minds of those who spread the rumors and also the recipients of such rumors. So building strong communication team will have to equipping them with the necessary tools to manage the root of those rumors. For example, what we do is we have an approach, and this can be done. You have an approach where you don't undermine the root of those rumors, but rather use that root as a point to spread forth the real information. At times, most of the time, where recipients or holders of rumors feel already have what we call a defense mechanism, where they are so very, very responsive to anything that wants to debunk what they have in your mind. So, and when they feel like their rumors are being attacked straightforward, they don't get the information you are trying to pass. But when they feel like the concern about your rumor is being addressed, but now an information is passed that they might have missed, it builds trust and it makes them want to listen more to what you have to say. And it makes them recipient to you the information. So this is what I think most communicators should take when you're building a theme and when you're also responding to rumors, so that you give an approach which is receptive to the people, which does not have your ego, what we call a rumor ego, who does not have your ego, but yet pass the information in a concise way that will make them feel like they missed something, and that is where they went wrong. So I think that is what I want to add, and it's very important that we take note of that. Thank you.
Thank you very much. In the interest of time, I think we'll move on to another important question that's been raised by several in the chat around the issue of seeing attribution in several of the presentations of the interventions to increases in vaccination uptake. And perhaps maybe Jory, you could take this one on first to talk about how do you do that? How is it that you can connect these specific interventions to changes in either community level or national level uptake?
Sure, thank you. And in terms of our focus as breakthrough action, it's difficult to do this type of a level of attribution with the work that is done in such a collaborative and a complex operating environment with many partners. We know that there are many aspects that are contributing to vaccination uptake, communication being one of them, and also many partners' efforts being involved in that. So through breakthrough action, we have done some assessments, as I mentioned, the CAP surveys, but much remains to be done. We've conducted a household-based survey concurrent with rumor tracking implementation. We've compared information cited by survey respondents with rumors identified through our rumor tracking approach. And we found a remarkable consistency between these two approaches in terms of themes and beliefs that have emerged. So this has helped us to gain some confidence that our rumor tracking sources are identifying real emerging rumors. But in terms of the question of attribution, and we also know that we're getting information that from user feedback that the system is relevant, that people are using it, and community contributors have positive perceptions of that system. But in terms of attributing it to vaccination rates, there are many factors, and we use the CAP surveys as a gauge of how attitudes are changing, but this is a very dynamic situation, and our main goal with the rumor tracking approach is to ensure that that we are addressing rumors in ways that are timely and relevant. So I will say attribution is not a main focus of our effort. We know that the increase in vaccination rate is a result of many factors.
Are there other presenters who might like to respond on that? Actually, Jep.
Hello, can you hear me?
Yes.
Yes, I totally agree with Jory in terms of the Safe Journeys campaign. We do conduct like rapid survey before we conduct the campaign, and also after this the campaign, we do brain lift studies to understand people's attitude about COVID-19 vaccine. That's what we can do to understand whether people like their trust in COVID-19 vaccine has increased or not. Yes. Over.
Thank you. So something else that's coming up in the chat is related to the issue of the adaptation of messages and understanding what you're learning from a number of the different social listening interventions that have been described, and the ability to analyze effectively and then adapt and translate that into new messaging. Perhaps Kashan or Anastasia, maybe you could take this just to talk about the kind of capacity that's required. Are there particular analytical tools? Again, what kind of capacity or training do you need to do with staffing to be able to take what you learn from social listening and actually do meaningful adaptation of messaging?
Thank you, Stacey. Now, that's a big subject. So in our case, I'll talk about us and I'll talk about it from the production and creation point of view. And in terms of contextualization and localization, I'd request Anastasia to come in. Now, from our perspective, we look at online social listening as a proxy for community sentiment. Our gap surveys and on-ground research often tend to be expensive, and we don't often have the time or the ability to do them as frequently as we need to. And with misinformation, the speed at which it spreads, we need a lot more dynamic community sentiment data, which cannot come from any other place but social listening. So our approach to this is that we look at every social listening every conversation online about vaccines and vaccination as an opportunity to address whether this is an information gap. Is it a potential misinformation? Is it heading towards a misinformation narrative that could come out of this? Or is this something that is just a query that we need to address right now? Based on this, we provide the countries with response recommendations. A lot of times, some of you might be surprised, our response would be not to do anything, even if you identify something that potentially looks like a rumor. The reason for that is that whenever you try to engage with a very small rumor, the likelihood of you spreading it further is greater than the original reach of that misinformation. So that kind of educates how we create our messaging. We start with the narratives that we've identified. We go to the country office, we get their approval on whether they also believe that this is something that needs to be addressed. Then we create the designs and the messaging based on the established SPC principles that we've agreed on with the country. And then we do A/B testing in the country to see how they're being perceived and what is the response, and are people perceiving these messages in the way that we need them to. And then we move on to deployment. But there's a big side of this conversation which is happening at the country level, at the misinformation task force level. And I believe Anastasia could give us a little insight into that.
Thanks, Kashan. So I think one of the biggest support and our ability to respond to misinformation was the tool that Kashan described, was actually message bank. So pre-prepared narratives, responses to the based on the sentiments that they tracked through social listening. So that was incredible, because again, the speed doesn't allow you to do a lot if there is not something pre-prepared. But then there are two other things that help us to localize. First is similar to message bank, influencers bank. So the list of people that we rely, we have them on WhatsApp, or they track rumors, we share with them rumors, and then we share with them proposed narrative, and then they adopt it through their language, how they talk, how they speak with their audience. And when I say influencers, these are not only celebrities, but also doctors, health professionals, people that are working in ministries, etc. So having like even 20, 30 people always available and really eager to work on this helped us a lot. And then the third thing is a co-creation. When you have a little bit more time to work on sentiments, to work on narratives. So when we are not speaking about rapid response, we gather, for example, religious leaders that were actually negative about vaccination. And we ask them sincerely, why? What are your concerns? We spend with them the whole day. So first half of the day, they were expressing all the frustration they have. And then on the second half, we ask them, what would persuade you to change your opinion and statements, how you address your communities? And then they started to say, okay, I would be more confident speaking about vaccination if. And then out of this, we actually built quite strong narratives on how to talk with religious leaders and through them with the communities. And actually, by the end of the day, I think most of them were more open to continue conversation, being initially extremely negative. So these are kind of the things we use when we speak about rumors and misinformation.
Thanks so much, Anastasia.
Stacey, if I may come in for a second, just in terms of beyond the points that Kashan and other panelists have mentioned, I would also like to highlight the importance of the collective and bringing together all the partners. I think that is a key also, especially in terms of when we're talking about like a rapid response and a high turnover scenario. So we can really build on each other's capacities on the ground. So if we have a functional RCC working group or whatever you may call it in your respective countries, that really makes a big difference. And we've seen that being effective in the Pacific Island countries, not just at the national level, but even at the subnational levels, where people were able to expand the outreach, respond much more faster and in a more proactive way. Thank you.
Thanks so much, Yoshi. I'm going to hand it back to Angus to take us through to the end of this session. Over to you, Angus.
Thanks, Stacey, and thanks to all of the presenters and to the various questions that we've received in the chat, to all of the participants. Just a couple of reflections to wrap the session, and I'd like to kind of bounce off what Kshitij just said. We often find when we talk about misinformation that we rapidly get into digital and into tools. And focusing on tools is clearly the tail wagging the dog. And what we've seen in the sessions in this session today is that it's not the tools that matter, it's the mechanisms and strategies that we put in place that capitalize upon the tools that are available to gather, consolidate data from multiple sources, both online and offline, into a single place where, and to make some sense of it. But then the second key thing is the people who then look at that and transform that into insights and recommendations for the teams in the field. So I think we've seen some great examples of national mechanisms for social listening that are doing all of these things, that are consolidating online, offline, producing in real time insights and recommendations. And this is really, it's great to see this set up, this happening in a number of countries with COVID-19. But as we've heard a couple of times, the hope should be that these mechanisms become embedded into the programs, into our national immunization programs, because we are going to be dealing with misinformation forever in our immunization programs. I think another principle that we've seen is that certainly misinformation and disinformation knows no borders. They can cross national borders in microseconds. They may sometimes remain within linguistic borders. They can move rapidly from online to offline. COVID misinformation can spill over into and affect other vaccination programs. But it's also important that we're not distracted by mis and disinformation. And we've heard repeatedly the importance of using these robust social listening mechanisms to understand the questions and concerns that people have, so that we're able to answer them. And then finally, when we get to answering them, we're talking about the same thing that we've been doing, but applying it online sometimes. So we saw the development of a network of online voices, trusted voices, similar to the offline networks that we have. The principles of making sure that everything's connected and that we've got these feedback loops operating in real time. And I think the final thing is, you know, these approaches can provide us with certain levels of efficiency. We heard about how 3 people were managing the inputs from over 1,000 volunteers by using a system that aggregated the feedback, visualized the feedback, and allowed them to then respond efficiently and easily. These systems can take both unstructured and structured data. We saw, you know, the input of CAP survey data, etc., so that, you know, we're really making informed decisions and providing informed insights. And also these tools can allow us to rapid test content in a way that we were never able to do before we put it out there, to hopefully get closer to the kind of relevance and resonance that people need in the responses that we provide to their questions and queries. And the very last point I think has come up over and over, the principle that we always have, the trusted influencers, the trusted voices, whether we're online or offline, they're fundamental. And the more we can do to equip them, to galvanize them and support them, the more effective we'll be. So with that, I think I'd like to close the session only 2 minutes late. I'd like to thank our speakers in the 5 sessions. I'd like to thank Stacey for co-facilitating with me today. Thank you all for listening. And now I'm going to hand back to Ombretta to tell you where we go next. Thank you all, everybody.
Thanks, Angus. So next is a 5-minute break, and then we go to Danielle Peddy for the community engagement session. So stay tuned, all about community engagement next, and please enjoy your break now.
Greetings and welcome back to this session. We will allow people to keep coming in, returning from your breaks. Hope you had time to get a fresh cup of tea. If you're just joining the session, welcome to you. And we will be getting started in just one moment. If I could ask each of the presenters for this session, please turn on your cameras for just a moment while we make the introductions. Okay, let's begin. Hello, everybody. Good morning, good afternoon, and good evening. My name is Danielle Petty. I'm a Deputy Director at the Bill and Melinda Gates Foundation based in Seattle. And I'm here today as your facilitator for the session on community engagement strategies to build trust in vaccination. So pleased that so many people have decided to stick with us. I know it's been a long 2 days, but very pleased to see we still have over 250 people. I think that alone shows the demand for this kind of communication and exchange. Today's session is last, but certainly not least. In fact, I think that we have saved the best for last, if I may, because community engagement and trust is, of course, at the center of everything we do, and communities are at the center of pandemic response and prevention and containment. So let's begin. We have 5 presenters today, and I'm really pleased to introduce them. The first is Kennedy Waitara, Communications Coordinator from the Solomon Islands Red Cross. Kennedy, please give a wave. Next, we have Dr. Kazi Faisal Mahmood from Breakthrough Action Bangladesh. Thank you, Dr. Faisal. Next, Banke Ivancliffe, Senior Immunization Officer from Value Health Africa, Cameroon. Banke, can you give a wave? Next, we have Kali Maluku, Communications Manager, Red Cross from the Democratic Republic of the Congo. Kali, are you with us? Please give a wave. And finally, we have Joseph Mbasha. Merci beaucoup. Yeah, and finally, we have Joseph Mbasha, Program Manager, Help Age Tanzania. As we begin today, let me remind you of a few items. First, we have simultaneous translation. If you need translation in French, Arabic, or English, please use the World button located at the bottom of your screen. 2 presentations today will be made in French, so for English speakers, you will need to switch to French interpretation at that time. Secondly, the raise hand function today is disabled due to the high level of participation. You have 2 opportunities to communicate with us. The first is through the chat function. And please, may I ask that you post comments, reflections, interesting ideas, resources that you want to share in the chat function. The second is Q&A. In Q&A, we ask that you please share questions. During the discussion, we will have an opportunity to answer your questions. And so please, if you have questions, put them in the Q&A and not in the chat. This will enable us to more efficiently channel your questions to the speakers at the right time. Okay, so let us begin. Community engagement strategies to build trust in vaccinations. We know how important trust is and how essential communities are to epidemics. We have a lot of emerging evidence and existing evidence for that importance. I want to highlight one now. A recent analysis of 177 countries in the Lancet found that pandemic preparedness indices measuring health security capacity were not meaningfully associated with infection rates or infection fatality ratios. However, measures of trust in government and interpersonal trust as well as less government corruption, had larger statistically significant associations with lower infection rates, and higher levels of government and interpersonal trust were also associated with higher COVID-19 vaccination coverage. These types of data emerging, data and evidence really are at the heart of what we're doing here today, talking about trust. Community engagement encompasses many different approaches. It's not magic, it's not an art, it is a science and a practice. It can be done well, with rigor, based on solid evidence and at scale. At the core of community engagement is trust. We know that trust has to be earned. Health authorities must be trustworthy. And also, trust is a two-way street. Trusting communities is as important as getting them to trust health authorities. Trust is about listening, and trust is about respect. Let's face it, people are complicated. Behavioral and social issues are complex and dynamic, and doing this work is not easy. Still, we have a lot of important practices that can be done with rigor and at scale, and community engagement to address the concerns of people, the perceptions and fears of communities is absolutely essential. Finally, community engagement requires sustained investment in community engagement systems. And this is certainly the case in this COVID-19 pandemic. These types of investments are best done not in the response, but before the response, in preparedness activities that require sustained engagement and understanding. So today, let us begin. We have our 5 presenters. Each will speak for no more than 8 minutes. And we will begin with our tour of the world in Solomon Islands. So Kennedy Waitara, communications coordinator for the Solomon Island Red Cross Society, will begin. Kennedy, the floor is yours, and thanks again for being here at such an odd hour of the day for you. Kennedy, please.
Thanks, Danielle, and hi, everyone. So I would like to present our work on community preparedness planning approach on COVID-19 in remote and diverse communities of Solomon Islands, and how that contribute to transfer of knowledge and community-led actions on vaccines uptake, and as well as positive behavior. Slide 2, please. So let me now start by giving an overview of our situation and our context in Solomon Islands. So Solomon Islands is a country with scattered islands and remote communities. Many of these communities are comprised of tribal ethnic groups that live within villages. The vaccine uptake until now is only around 25%, and these is percentage of those who are fully vaccinated. The health systems here in Solomon Islands are often without adequate resources, and there is also lack of clinics in many locations, and that also pose challenges in itself. And as I've mentioned, Solomon Islands communities in general live in close-knit families. Now, based on the secondary data, community feedback, social monitoring, and regular interactions with community members, we have come to realize the challenges that are there here in Solomon Islands. And as you can see, misperceptions and lack of information about vaccine also some of the challenges, and that many of the communities are remote services or information are not easily accessible, especially for the older people. And communities have also shared safety concerns, as well as effectiveness of vaccines, as well as fears of side effects or health issues after getting vaccinated as well. We have also noticed community being against the vaccine due to religious beliefs or beliefs that traditional methods work better than the vaccine. And given that many of the communities are remote, service or information are not easily accessible, especially for the older people, there is also a lack of community preparedness, meaning inadequate social measures or plans in place, all of which greatly increase the risk of contraction among vulnerable groups, more especially those elder people. Next slide, please. So data from the RCC collective service, as you can see, indicates that while the willingness to vaccine has been growing, vaccine uptake in general has remained very low in Solomon Islands. This is compared to other countries. And as I've said earlier, fear of side effects, religious beliefs, and vaccine efficacy are hindering people from uptaking the vaccine. Currently, vaccine sites in general close to urban centers and not so much near the rural areas, which sometimes make it very difficult for community members within rural locations to be able to be vaccinated. Next slide, please. So a lesson learned exercise was organized following a mock lockdown in the country in July 2021, which was identified that there was gaps in community preparedness, especially in event of a COVID transmission. And so based on a consultation with Ministry of Health, we rolled out the community preparedness planning approach on COVID-19 into 15 communities. And we use the WHO Community COVID-19 Pandemic Planning Guide for this activity. And as you can see, we've started by first conducting volunteers training at the headquarters on the community preparedness tool, and then continued the training for volunteers in the local branches or provinces. The volunteers that were trained were part of the community, and so they were quite familiar with the social contract in those construct in those provinces. Together with these volunteers, we organized workshops on COVID-19 preparedness plan with the communities. This is where we included a cross-section of the community members, including elderly and representatives of the tribal groups. We also supported the creation of COVID-19 community committees. Again, this included members who are older, members from tribal groups, people with disabilities, men, women, and younger people. The committee was assigned with special roles and responsibilities to roll out the social and public health measures in the community. And together with the community and committee members, we were able to facilitate the development of a plan of action. And this covered various topics such as how to share information with community members, who to contact for information on the disease and vaccine, what to do in the event of a community transmission, and so on. We also ensured information sessions during a workshop on various topics around vaccines, such as how the vaccine work, its safety and side effects. Following the action plan, committee members organized information sessions on COVID-19 vaccine, involving religious leaders, nurses, and also sharing information house to house. The members have been promoting community action, encouraging communities to get the vaccine, as well as practice health behavior, such as wearing masks, maintaining physical distance, washing hands with soap and water. They also capture feedback and as well as address misperceptions about the vaccine in the community. At the moment, we have 15 community preparedness plans developed, and as well as 170 community members, more than 170 community members who have participated in our preparedness planning exercises. Next slide, please. So to understand the progress, change and perception of communities about the disease or the vaccine, we meet with the community leaders on monthly basis. All these community leaders include religious leaders, tribal leaders, men, as well as youths as well. We also consult with COVID-19 committee members regularly to understand what actions have been implemented, community perceptions or community perceptions, and any support they required. We have also established the community feedback mechanism to capture questions, perceptions, concerns on vaccination and vaccination efforts, including access to services. We have rolled out feedback system since April this year. This feedback shares an overview of the community's needs and perception about the disease and the vaccine, and helps us understand where we need to improve. The committee members, as mentioned in the previous slide, also supports the collection of data. Based on the feedback data, we have been sharing factual information as needed. Preparedness plans and actions. With the support of committee members, we have been able to raise awareness among communities. There are regular church announcements to talk about the vaccine and encouraging people in the uptake. Support the adaptation of various cultural practices to reduce the contraction of COVID-19. Next slide, please.
Kennedy, you have 1 minute.
So communities are better informed. They have access to information. They know who to contact or reach out for questions, feedback, or in need of services. Communities are also leading action to minimize the spread of COVID-19 in their community by following the preventive measures and encourage others to promote positive behavior. COVID-19 committee members play a critical role to support with information and vaccines to the communities and counter rumors. And we are receiving more feedback, positive feedback from communities about the vaccine and their willingness to get it. The intervention was inclusive and ensured participation of various committee members, including the elderly and tribal groups. Having the cross-section of committee members to take part in the planning exercise ensured that we were able to identify the priorities and gaps and how they could be addressed. Engagement of tribal groups and elderly in the planning process, and also being representatives of the committee, helped advocate for vaccine uptake and positive behavior. We have also been able to mobilize volunteers who from the communities and had good understanding of cultural norms, beliefs, and practices. We also had the committee members who supported the dissemination of information and rollout of the activity. So the approach manifested the transfer of knowledge and reach of remote communities. So while there have been a rising trend in the vaccine uptake, we continue our community engagement efforts to answer community questions, their concerns in vaccine, have dialogue to promote vaccine uptake and ensure positive behavior. Thank you so much.
Thanks a lot, Kennedy. Really excellent presentation on the hyper-local interventions in Solomon Islands, and we will come back to this in the discussion. As a reminder, please post questions to Kennedy in the Q&A, and please chat comments and thoughts and reflections in the chat. We're moving now to Bangladesh. So Dr. Qazi Faisal Mahmood from Breakthrough Action. Dr. Faisal, the floor is yours. Thank you. Dr. Faisal, are you with us?
Yes, hello.
Okay, great. The
Okay.
floor is yours. Yes, you have
Okay.
8 minutes.
Thank you. Good morning and good afternoon, everyone. today we will be presenting some information and our learning about the community radio, but want to add at the beginning that the interventions we had in USAID's breakthrough action in Bangladesh, it was not only the community radio. So we had a lot of intervention like mass media, social media, other community groups, the conjunct activities, the other social listening activities as well. But here I am sharing only the community radio approach. Next slide, please. So the situation, if we want to share the situation, Bangladesh had a high burden of COVID-19, and we had three major waves till date, and we are like going into the fourth phase, unfortunately. But the another problem is that national vaccination program that was launched by the government in January 27, 2021, with a target of 80%. And you can imagine this 80% is a huge population, over 130 million population. So in the first phase, we aim to vaccinate 39.5 million people. And what we have observed that there was a registration process, and this registration process is not very familiar with a lot of people, and that also had some problem. And 46% of the adult population reported that vaccine hesitance, and 18% eligible people had registered for the vaccine only. So there was a lot of problem with the registration. And the major barriers of the registration was lack of knowledge and conspiracy beliefs around that. Next slide, please. So what was our solution and how we did want to cover? We did identify different strategies that focus that community radio. They can reach, we did identify specific target groups like elderly, rural, semi-urban, very poor population, and tailored messages for them. So for each group, we had tailored messages. We had partnered with 1 FM radio and 16 community radio stations. We developed public service announcement, drama series, inter-education shows, and Facebook Live, at the same time phone-in programs. One interesting thing is that because the community radio is covering around 40 kilometer dia of the community, so we wanted to customize the folk songs, local folk songs, to address barrier in getting vaccinated. And we conducted community miking. So another important thing is that along with the community radio programs in the radios, we did also conduct community miking sessions through the radio station. So this miking station both facilitate the information about the vaccine, at the same time about the programs. Next slide. Our impact and lesson learned, we wanted to show that, okay, being community radio, they had a huge reach of around 20.6 million, and these are very cheap in terms of the programming, and they can also tailor local programs. One anecdote that one of the community radio station presenter, she herself mentioned that her mother-in-law was hesitant to take the vaccine. And she was telling that after listening to the episode that she was presenting that addressed the vaccine, COVID-19 vaccine related side effects, myths, misinformation, rumors, she decided to get vaccinated. So like this is straight from her own experiences. The lesson learned, we have a lot of community engagement through the phone-in programs and others, we have identified that, okay, people are interacting and they have a lot of questions. We tried to bring expert in the community shows. So people were really interested and they were sharing their different concerns about misconception and other related issues. The community radio, social media, micings, all these three were very useful channels in reaching the vaccine hesitancy program. At the same time, another lesson learned was that the folk songs, drama, talk shows, like if you use different formats, it does help you in different aspect. At the same time, they will allow you to tailor messages for the audiences. So I think next slide. And like I want to conclude with one thing that, okay, only community intervention cannot work together. So we have to sort of have a combination of local media, mass media, traditional media, and others. And through that combination, we can really achieve whatever we are planning here. We would like to share here that, okay, these community radio programs were also taken by different social medias, and they did share. I want to add here and thank all the community radios that worked with us. At the same time, with the community like stakeholders who were involved with this project. So thank you very much.
Thank you very much, Dr. Faisal. Really interesting presentation on radio as two-way communication. And I know many of us will be more interested to hear about this community miking approach. As a reminder, please keep your questions coming in the Q&A. We'll come back to those in a moment once we have this tour of the world. So we've moved from Solomon Islands community action planning to Bangladesh community radio as a two-way communication tool. We're now moving to the African continent. So we're joined by Mbangi Levankiv, Senior Immunization Officer, Value Health Africa, Cameroon. Mbangi, the floor is yours. For those who need translation, please remember we do have translation in French and Arabic. Just hit the interpretation icon on the bottom of your screen. Mbangi, over to you.
Okay, thank you very much, Danielle, for that presentation. So I'm Levankiv Bianke from Cameroon, and I'm the Senior Immunization Officer and Community Engagement Officer. So I'll be taking you through our novel approach that we use in order to engage the community to build confidence and trust in COVID-19 vaccines. So I think we should go to the next slide. Okay, let me just give a roundabout background of what the scenario in Cameroon. You know, Cameroon has been hit by a political crisis which has lasted for over 5 years. So our approach was focused on the crisis-stricken part, which is the Anglophone region of the country. And according to the WHO report in December 2021, it shows that only less than 2% of Cameroonians were fully vaccinated against COVID-19, and only 3.9% of the population had had a single dose of COVID-19 vaccines. And the same report reported the poorest rate of COVID-19 coverage within the northwest and the southwest region of Cameroon, which are the regions which are in crisis now. And also what we had as a problem is there have been little engagement by the government in improving COVID-19 vaccine coverage. And this is particularly because the communities and the population has been hesitant to government delivery services. And a report from UNICEF in 2019 reported that just about 7% of the population, of the Anglophone population, is seeking service delivery in the public structures. So we are faced with a very hesitant population, which are not only coupled with rumors and misinformation, but also in a highly political atmosphere that has contributed to the hesitant nature of the population. Next slide, please. So as a measure, what do we do? What did Value Add Africa do? We had the first time we had as a task to understand the dynamism within the communities, the perceptions within different groups of the communities, to know what is the source of the hesitancy and to know the strategies that we can employ to engage the communities and seek various ways we can bypass rumors and misinformation, as well as bypass the political indemnity within this specific group of population and get the communities engaged in seeking COVID-19 vaccines. So the very first thing we did was we looked at how we can make use of routine immunization tools, because Value Add Africa have been involved in routine immunization, and we have been using several novel approaches such as the HID, the HCD, and also microplanning tools. So we were looking at how we can make use of the advantages these tools bring and how we can integrate them in understanding the communities for COVID-19 vaccine trust building. So we divided the population into several groups: the elderly, people living with comorbidities. We also look at the population, the frontline health workers, and IDPs, which are the internally displaced population. So we use key informant interviews, which are the KI interviews, and we interviewed key community leaders. They were comprised of administrative leaders, they are comprised of religious leaders, women leaders, men leaders, youth group leaders, and also various groups such as adolescent groups within the population. We carry out key informant interviews to understand your perception about COVID-19 vaccines, and also to understand what they know, the knowledge they have about COVID-19 vaccines, and to also try to get a perception about the various sources of information, where they got their information, and what need to change if they are to accept COVID-19 vaccines. And we also use this. We also use frontline health workers to get information about what they think about this vaccine, because we realize that most of the time misinformation and rumors are being spread by frontline health workers, and they themselves have become hesitant to the vaccines. Just imagine if a health worker is hesitant to a vaccine, streamline that to a population which is already there, and you can get a scenario deep down to the population. We don't have access to the level of information that health workers have. So using this micro plan and HCD approaches, we got a perception of what the community think. So using this wealth of information, we develop SBC communications for each specific group. And we also I want to stress that we also use existing groups such as diabetic clubs, UPEC centers, fitness clubs, elderly homes, and social groups, so that we get a complete representation of the population, so that we can understand what are the perceptions of the population, the specific groups, and also what are the prevalent thoughts within specific groups, and what are the strategies we need to develop to tailor to these specific groups of populations. So what we do using this information, we develop community dialogue structures where we give the people the power to design strategies for themselves, because we realize that strategies need to be from bottom to top, which is the microplanning approach, bottom to top, and not top to bottom. So we give the population the power to influence decisions, to design these strategies for themselves. Let them tell us what we need to do, what need to change for them to feel confident, for them to have trust within this with these COVID-19 vaccines. And we develop tools, what we call confidence tools, confidence meter, that we use to measure people's progression. In the dialogue structures, we have pre-assessment, people's confidence pre-assessment tool, where we get their confidence level when they got into the structures. Then we have post-assessment tool that we got their confidence level. After this, they have had series of dialogues with us and our community team leaders and our community experts, our communication experts, to get their confidence level after a series of sessions. And also, we try to understand their progression in confidence from one session to another. So how did we measure our success? First, we use the the confidence method tool to track the progression of participants' confidence within the dialogue structures. Second, we develop referrals that we're giving to the population when they get into the COVID-19, when finally they accept to take COVID-19 vaccines, when they present themselves between the COVID-19 delivery centers, they give these referrals to the centers so that we go now back to the centers to know the number of people who were vaccinated from the dialogue structures or from our activities. And also next, we look at the district data report, and it showed a massive improvement of the immunization coverage within the communities, because we selected communities which are pilot communities. We could not carry this out in a whole lot of communities due to a resource constraint. So we did this in pilot phases. So yes, what are our outcomes? Like if you look at this year, look at December, from December 2021, in the Southwest, you have 0.8% coverage. And in the Northwest, we have 0.6% coverage. But look at our report in April 2022, we saw an increase in coverage to 3 in the Southwest from 0.8 to 3.9. And in the Northwest from 0.67 to 9.1. That was a great increase in vaccination coverage. So, friends, what were the learnings that we had using this approach? The first thing we understood is giving people the ability to design strategies for themselves works best in such scenarios. The people feel confident if they are engaged in developing strategies, if they are engaged in the process, if they are engaged in the planning, and if they are engaged in the implementation of those strategies. They feel like the strategies are developed by them and are implemented by them, thus they feel confident in whatever strategy you are trying to put in place. The second, treating each community as an individual context will help you tailor strategies specific to communities and also specific to various age groups, various subgroups like people living with comorbidities, IDPs, and then you'll be able to reach out to the target needs of each specific groups. And lastly, as a key learning, we see that integrating other tools used for routine immunization, such as the HCD and microplanning, have great impact and great positive gains in improving COVID-19 vaccine uptake. Next slide. So guys, that is what we have. That is the new approach we have. Like you see in the pictures there, we have women group discussion in this other end, and also the newspaper report that was that the work of VAHA was captured, and VAHA was given an award as a leading humanitarian award for COVID-19 vaccine uptake in Cameroon. So thank you, Bryce, and I'm very, very open to receive your questions and comments. Thank you very much. Over.
Thanks, Bianca. And you'll be happy to know there are many questions in the Q&A. So please start looking, because you have a lot of really interesting questions coming your way. In fact, several of them are relevant to the other presenters. So Mbiake, thanks for really emphasizing the work you've done to build bottom-up dialogue and strategies that are community-led and driven. We are going to stay on the African continent now and continue our Ignite presentations. Next, we have Kali Muluku. Kali is the communications manager for the Red Cross of the Democratic Republic of the Congo. Kali's presentation is in French, so please switch over if you need French translation. And Kali, the floor is yours. Thank you.
Merci beaucoup. Je voulais, avant de commencer ma présentation, remercier les organisateurs qui ont
Thank
bien
all the organizers who wanted to invite us for this World Summit to share our experiences. And this is something really what is well done by us in the Democratic Republic of Congo with the help of the government. So we can pass to our next slide. So the situation is as following. Regarding the Democratic Republic of Congo, we have understood that actually there is an uptake among the people who want to be vaccinated. And we can we can understand that by using our feedback mechanism. So we are listening to our community to understand what is going on, what are the perceptions. And we have understood yet that there are some problems which are persistent, which are connected to the offer and to the demand. So the problem is that those vaccination sites are very difficult to reach. And we have also understood that this demand is minimal because the vaccination campaign is mostly organized in the cities and not in the countryside. Also, we understood that the strategies launched were not inclusive enough to include the most vulnerable persons. We have the elderly here, the minority groups. We also have handicapped people. We also have blind people. So all these categories are not accessible for vaccination sites, which are being far away from their homes. And that is why we have organized for this purpose some activities to accompany these groups of people to facilitate their access to vaccination. For example, we have launched provisory vaccination site, and it allowed us to bring the vaccines to the people who needed them. We have also organized a lot of communication on vaccines, on vaccination. So we have also albinos communities, which are also considered marginalized categories. So we tried to adapt the messages to the languages which is being spoken here in Kinshasa. There are different languages. There are 4 official languages. We have translated the messages to bring the information to everyone. And these messages arrived to the communities, and they were trusted information because, first of all, we prepared we tried to identify trusted people to share them, and we used different communication channels to transmit them. We also organized vaccination campaign using our volunteers, because very often they were asking us whether you are being vaccinated. We have organized a campaign to show them that we are not doing something that we are not asking you to do something that we are not using ourselves. So we have invited volunteers for vaccinations, and then also regarding the handicapped people, we propose them logistics measures so they can so we can bring these persons to the vaccination sites. So all these activities allowed us to be able to have the results, our results. And thanks to the mechanisms that we have launched, we could implement the work which started from August 2021. You have a big arrays of number of questions and suggestions regarding the vaccines. And so people needed to know all the information about the vaccines. And so the people are ready. They want to know what are the conditions to get vaccinated. And this is a permanent work in the Red Cross because this activity, which is monthly held. And so every month we get the information, we analyze them, and we contact the community to understand the situation, because we need to understand which are the perceptions of the people. And thanks to our efforts, we could contribute to the situation where is more interest and more and less hesitancy.
So, listening to people is a way allowing us to ask the correct question, to have such a dialogue, and also to take decisions with respect to what has to do with deciding over vaccination. So, in order to achieve the wanted targets in terms of trust, this type of communication is crucial, so as to improve trust and to preserve it vis-a-vis our community in this fight against COVID-19. This also allows us as organizations to obtain crucial information with respect to what the community thinks, and so that we are able to propose the right things, what they expect. If we put together all these elements, we can say that we can have a fully fledged system, also thanks to this type of loop that we are able to close. So we propose, we analyze, and we listen to our community. This allows us to develop some customized measures vis-a-vis the different community representatives. This also allows us to identify the most important key indicators so as to identify also the right person or entity that is the one who has to implement the needed procedures or services so as to provide the correct answer. This is important. We have experienced it. The work starts thanks to the work carried out by volunteers. They gather information and we provide them with the needed information. We review such information, and by so doing, we design and devise the correct strategy so as to try to provide a follow-up with respect to what we got from the community in terms of feedback. Next slide, please.
Kali, you have 1 minute.
I just wanted to say that this is the type of work that we carry out. The person that will take the floor after me should talk about the different social media and how we interact with them. Thank you very much for your attention.
Thanks, Kali. Really, really useful and quite detailed presentation on your experiences in DRC with respect in particular to the community feedback mechanisms. Questions for Kali, please continue to post them into the Q&A. There's quite a few questions building up, and we have one last presenter before we can get into the discussion. So Joseph Mbasha is a program manager at Help Age Tanzania, and Joseph will be sharing some of the experiences from Tanzania. So Joseph, over to you.
Thank you so much. Good morning, good afternoon, good evening, everybody. I'm seated in East Africa. Here it is evening, so I wish everybody good day. So I will be sharing you a bit of experience of Tanzania through HelpAge and under UNICEF support, how we managed to access COVID-19 vaccine equity and the access for older people, but also those who are most at risk. Slightly, you can see the pictures here giving 3 postures of the older person being vaccinated in the car, the other groups on the dialogue being the intergenerational sessions held, but the last one on the bottom one and having the home visit through the home care volunteers. So these are the 3-tier approach that mainly we have used to read to the Equity Act, to the vaccine equity and access mostly for older people and those at risk. Slide, another slide. Sorry, that is not.
Yeah, go on. I think we mixed the slides. Go on.
Yeah,
Exactly.
Yes, exactly. Yes, thank you. So overall, you can see Tanzania is really not fairly doing well in terms of the vaccine. You can see across we're still, this is basically the March statistics, but we are very low, below the 10% coverage, at least with some increase we'll see later on in the next slide. Next slide. Yeah, so overall, the Tanzania joined the rest of the globe very late in March 2021 to report on COVID-19. Most of you might be aware that the government had a little bit of the hesitancy to report on that. And we later joined COVAX in July 2021. I think most of the other countries had already joined. But and then when we joined, we started with the frontline workers before we now covered the risk populations. There was a very low uptake of the vaccine that we're especially now looking on the older people with due to various barriers. Some of them has been earlier mentioned by other colleagues, but mostly looking on the perception, the rumors that were behind the COVID-19 itself. But the country has now decided to target 70% of the total population to be vaccinated from the age of 18 and above, where we are talking of population of 61 million, but now from the 70% target, we are now looking on around 42 million and 100 plus. And this is by December 2020. And to date, we are talking of 19.57% of the total population that being vaccinated, but at least received at least a single dose. Now, the problem basically from the older people's perspective was the question of the limited exposure on the information that were received, that were sometimes not reliable, and were not coming from the reliable sources. And given the fact that the government had now announced from reporting on that, then it highly matched the things. But overall, there is a limited health-seeking behavior which is coupled with, the high level of ageism among communities. And now, with that kind of aspect, you can see now how other people would be hesitant to really seeking for or rather looking for the vaccine itself. The hangover from the government's denial was very rampant and very strong. So it was really challenging to really eliminate that kind of situation. But overall, globally, the statistics were still indicating that fatality among older people was very high, and among older people and those with the underlying conditions. Next slide. So how did we come? What did we come as a contribution? We thought of coming out with three approaches. That was to do with the peer awareness creations, where we are working with Older People Association. We do have what we call Older People's Association across the country, from the very bottom, community level to the national level. So we tried to use that to iron out the wrong perception, the rumors that were surrounding the COVID-19, but also the vaccination itself. But then we now worked with the volunteers through the existing structures within the communities who are working with the home-based carers, village health workers, but also we have those we call the active aging clubs. Those members now, through the volunteerism approach, to disseminate correct information on the vaccine. But then we also indulge on supporting the outreach vaccination program through mobile facilities. Next. Yeah, so what action did we find there? Then we learned that facilitating community engagement dialogues was used to clear misconception, myth, and the rumors. And this was done purposely by engaging different groups, older people, youth, but also with the middle-aged groups, meeting together and then try to iron out the issue, the concerns, and then through their own experiences, but also with using also the experts to clarify those myths. But we're also using some part there. This element that probably the COVID-19 were coming to eliminate the age groups. So we are bringing now in youth to also support that. They need to show trust, but also to give confidence to the other groups that, this was as any other pandemic and it was not targeting any group. But then we supported the outreach vaccination program through, especially in the remote areas, but also in reaching very challenged individuals. And this really created the trust among community members when we are now moving toward, the very challenged individuals at their home places to get them vaccinated. So that also created a very strong confidence and the trust among the viewers and the communities. But then we engaged the volunteers through the home-based carers, the active aging clubs members, but also the young volunteers with the health workers to conduct these outreach services. Now at the measurement to see how this we are really performing a little bit, but then we learned that having a designed community maps that identified older people living with disabilities to create access to vaccine in the most hard to reach rural areas really required an existing community-based monitoring platforms. So we had now to engage in, of course, identifying, knowing exactly where and who should be reached at what particular moment and at which means, so that the wider community can be reached, but also the similarly way you are also sending messages to other members that this is something to be highly prioritized. But then we conducted the monthly home-based surveys to collect data through these volunteers, collecting data to know exactly how many received the vaccine, how many still hesitant, and what are the reasons, and then come out with the strategies, whether to conduct the community dialogues or rather whether to indulge more of the mobile of the outreach services. But then we used also the national vaccine data as part of the to compare where the areas that were operating and the other areas where we were not, but also for the advocacy reason, but for the advocacy purposes, but also for sharing with the other areas and the other practitioner areas.
Joseph, 1 minute, please. Thank you.
Yeah, so the outcome of this, we started with the pilots earlier in the 2 regions, where we realized that in only 3 months that we approached the 3 approaches, we increased the vaccine among older people for the 99% as compared to other age group that was on 88. Now later, when we extended it to other 5 regions, we managed in the rest and in the span of 3 months, we moved for almost increasing by 40% for the vaccination of older people and 25% for the people with disabilities. And then from that approaches, we very much attracted, other stakeholders, but also the government to now seriously prioritizing older people as the beneficiaries, but also for the advocacy campaign. But also we managed now to minimize for the greatest extent the rumors and the misconception that were right around the COVID vaccine, but also the vaccinations. So the learning to us is probably the approach toward the peer-to-peer awareness is key. But having also a trusted organization, like the combination of HelpAge and UNICEF was really key from the trust that the 2 organizations had in those communities. HelpAge with the focus on older people, but UNICEF with the vaccination and the vaccination champions in various ways. It was really very much, motivating, others to really agree and move out to receive vaccine. But also availability of structures like the volunteers within the communities is key really to support the massive spread of the services and the campaign, as well as also the vaccination program itself. And community dialogue, at one hand, we find it is very, very key in amplifying, but also in clearing misconception quite easily, but also it can also be used for further, directional intergenerational engagements. Like we managed to address issues of ageism, but also issues of sexual reproductive health, which was beyond what we planned in our design. Next. Yeah. So generally, that were the 3 approaches that came out, and we really think if it is well studied and designed, it can really help to amplify more and have more bright impact on this situation where it seems to be stagnated. So thank you so much.
Thanks, Joseph. So could I ask all panelists now to please turn on your microphones? Kennedy, Dr. Faisal, Bianca, Kali, and Joseph. We're entering our dialogue and Q&A. Community engagement is all about listening, and we've been listening and reading all of your questions. Unfortunately, we may not have time to answer all of them, but we can. I noticed there's some key themes we can pull out. So let's get everyone on the screen, and we'll start. I picked out 3 key themes emerging from the questions. Questions about gender and challenges with respect to differences in gender, questions around integration with other strategies, particularly routine immunization and other health interventions, and questions around operational models. How much does it cost? How do you move from pilot to something more scalable, given the resource intensity? So let's start with gender, since we have a group of 5 men in the field. Dr. Faisal, let's start with you. There's a couple of questions on gender dynamics and how that factored into your work and what challenges there were with respect to the radio interventions. Over to you.
Thank you. Gender dynamics was really an important part. Number one, as you see that during my presentation, I have seen that in terms of vaccine uptake, there is this vaccine uptake by the women. So we had to also tailor our programs that are compatible for the men and women, everyone. So what we did in terms of gender integration, we had programs in collaboration with the partners, and there during the message matrix development and during the overall program planning, we have identified that, okay, how much we will be focusing in terms of identifying characters, identifying the actors, at the same time integrating it with the social media. We had a real analysis and planning at the same time, working together with the partners. Besides, there had been also gender disaggregated data from the government. We were receiving like in which area which gender is more. So as because we were working with the community and we have a definite working group that within 30-kilometer diameter of the community radio, that is our working station. So we have identified the eligible number of men and women, and we have sort of developed our strategies based on on the uptake rate, hesitancy, and others. Thank you.
Thanks, thanks, Dr. Faisal. Kennedy, I want to pass to you because there was also some questions. Dr. Faisal shared some reflections in terms of the planning, in terms of data collection. Could you share a little bit more about how you factored in gender and differences between men and women, boys and girls, with respect to the actual community engagement strategies you utilized in Solomon Islands? Over to you, Kennedy.
So during the planning process, what we've done was to ensure that our female and sort of a cross-section of the community are part of the planning process. And so we have to ensure that our female are also part of the planning. Not only that, but as well as male as well, including youths and elderly, and where people with disability are able to be part of it, then we also include them in the discussions during our planning sessions.
And Kennedy, did you notice any key differences or key issues emerging from these tactics?
So from what we find, including the cross section of communities, people, gender, it helps a lot in terms of the fact that tribal, in villages there are cases where messages can be well sort of passed on by groups as well. So like in terms of groups that are existing in communities like women's groups, information, for instance, with regards to vaccination, female members within committees can also be helpful in terms of ensuring that messages around vaccination is also passed to various female groupings within your communities. Not only that, but as well as in tribal groups as well, knowing that it's not like mostly it's often females, so it's not so much males who often like talk to females. I mean, sometimes it's not culturally appropriate, but that it's have to females who through their groupings or even the just daily chores, they can share information.
Thanks, Kennedy. So so let's move we can always come back to gender, but let's move to this issue, this second sort of big topic where there are a lot of questions around the issue of integration. And there were a few questions here, both in terms of integration with routine immunization, as well as integration with other health interventions, and integrating this COVID-19 emergency work with broader health interventions that may feel more relevant to communities. Let's start with Bianca, because I think, Bianca, you highlighted this quite strongly, the work you're doing to integrate some of the social behavioral community engagement interventions with existing immunization tools. Can you share a little bit, what have been the top 1 or 2 challenges for you with respect to integrating some of this work within routine immunization? I'll pass to the other panelists in a moment, so please be ready to answer the question on integration of these tactics within broader health work. Bianca, over to you.
All right, thank you very much, Daniel. I think when we talk about integration of COVID-19 into other routine immunization and other health packages, we have been having a lot of discussions, and currently we are still having high-level discussions to see how that is possible. And I must say, when we talk about integration, we are talking about integration in different levels, at different level. What level of integration do we need to introduce per time, which is a very important question. So what we did is we did integration at the level of tools. So we did not have much challenges because we were just utilizing the tools that have worked for routine immunization. So we did not have much challenges, and the population was very flexible to provide us with the information that we needed. So, but when we are talking about integration in terms of service delivery, it's a whole lot different, and we are envisaging in having challenges when it comes to that level. So right now we are doing a lot of brainstorming, a lot of planning. We know the communication about integration is very important, and as long as it is done well, and I think personally, and in our organization, we believe that integrating COVID-19 in other health service packages, especially routine immunization, is of great benefit, because a lot of talk, especially within the African region, where many people feel like COVID-19 is not like the top of the list. We have malaria, we have HIV/AIDS that is destroying the population, killing lives, and why are you talking about COVID-19? So integrating it will be of great benefit to the African population. But as well, we must be careful on how we go about integration, because we can have a lot of setback and we can undermine the progress and the gains we have had in other health interventions. So we are having a lot of discussion. I think a lot of brainstorming needs to be done, a lot of planning needs to be done, and this has to be done in stepwise. Integration needs to be done chronologically from one step to another, revising, monitoring, evaluating the process, getting data on feedback, progress, and also backlash, and see how you can refine strategy at each given stage. Yeah, thank you.
Thanks a lot. Kali, do you want to take this question as well? I think it's an interesting one. How do you respond to this issue of practically speaking in your interventions? How are you integrating this work within broader work, given the fact that COVID vaccination may not be the first priority in the communities where you work? Over to you. Kali, the question is yours. Yeah. Oh, maybe while we wait for Kali, Joseph, do you want to share any reflections?
Yeah,
Yeah,
I really
hello?
think
Hello?
that is really critical, and through our experience, that was very often coming in when you are talking with other people. The key question was, why so much attention on COVID-19? Why do we have the NCDs, which is very rampant in our communities? We have cancer, the prostate cancers going on. Why can't you really have, a special program on this and then aligning with, the COVID-19 campaign you are doing? It was really hard, challenging, and I really think having an integrated programs around this can really make it more effective, but more attractive, maybe to say so, because otherwise now it remains creating the rumors around that problem. Why is that much emphasis on COVID? Is there any financial implication on this? So to us, like in the other campaigns, what we did was like to have, a general community, health campaigns where we are now inviting for the health checks. And then out of that, then the aspect of COVID-19 awareness creation was coming in. And this, in other ways, now was desensitizing these negative perceptions and the rumors that were surrounding that. Then we are seeing like we are approaching it in a more general health approach, and we are aiming really to have it more sensitized across the other healthy related conditions to the particular group we are addressing. Yeah.
Thanks, Joseph. And I imagine that because you utilize existing structures and networks in your model, it's probably a bit easier to do that. Kali, do you want to unmute and add any points on integration within your context in DRC? I can see you, but I
think maybe there's an issue with translation.
Okay. Okay, I understand. Okay. Sorry. So
he's now unmuted, I think, Kali.
Oh, okay, go ahead, Kali.
Je voulais avoir la question parce que j'ai un petit souci des réseaux, je n'ai pas bien suivi la question.
Can you please repeat your question, because I had some connection problems, so I couldn't hear it.
Sure, Kali, sorry for that. The question was about integrating these COVID-19 vaccination community engagement strategies with broader health interventions in DRC. What are your experiences, your challenges, and your thoughts with regards to integrating these tactics with other interventions, given that most communities or many communities may not see this as the most important issue they are facing today? Over.
Oui, je pense que...
Yes, I think that this is the work we are implementing in the community. The COVID can touch everyone, so we have to be able to take countermeasures against this disease. And in DRC, we have, of course, different activities against COVID. So we have activity which is already being integrated in our health measures. And so we are accompanying government efforts. We are working together with the communities to control the situation. One of very important measures is to promote vaccination. In the beginning, people were skeptical. They were saying that the vaccines is something not good. And when the government took necessary measures, so that has changed the situation, and that is why we could really contribute to the countermeasures against the pandemic. And as we are also collecting a lot of information, which we are sharing with the authorities, with the Ministry of Health, and which allows us to see which actions we would like to undertake to be able to change the tendency, the trend, because COVID today is a reality. Everybody knows it's existing, it's real. And people now are even demanding vaccines. People are asking us, where can we get vaccinated? Where can we go? And so we are promoting vaccination, and we are trying to, in the Red Cross, we are trying to use our transport means to bring the people to the vaccination sites. And we also had a question about the albinos. We are working with local associations of albinos. We are organizing information sessions to explain them about this disease. Those people who are favorable for this vaccination, who want to get vaccinated, we help them to do so. And so we also have a picture with the albino person who is getting vaccinated. So we are working not only against COVID, we are also working with all the diseases at the country level. We have integrated COVID into our control measures. We are also collecting the information from the community, and we are trying to really track all the questions in regards to all these diseases. We are working together with the Ministry of Health. So we are undertaking measures with the community, with the Ministry of Health. We are trying to engage more the communities to fight against all these diseases.
Thanks, Kali. And I think this is these are some of the complexities I think that you're facing. And so let's move now. Integration is a really big topic, and of course, we all understand that we need to move away from siloed approaches to vaccine delivery. But doing that is complicated and needs to go step by step, as Bianca mentioned. Let's Bianca, let's go to you, because there's a couple of questions in this third area, and I want to make sure all presenters have a chance to respond. This third area of operational models, there were two questions for you. One was related to the cost, in human resources and time and etc. It seemed to one questioner that this is quite intensive approach. So how would you respond in terms of what are the costs, and related, how do you then take this type of model to scale? We'll need to wrap up, so I'll ask Bianca to respond, and I'll also pass to Kennedy. Can you share a bit about your operational models, their costs, the time, the effort, the labor, and how you think that these types of hyperlocal interventions can be scaled efficiently given resource constraints? Over to you, Bianca, and then we'll go to Kennedy before we close.
All right, thank you very much, Danielle. I don't know why they had a perception of having a very big cost effective, but to be honest, it is not cost intense. Why? Because we utilize already existing structures. So it's not like we were building new structures. Micro plannings are already being done at the level of health facilities, at the level of the district as well, and also they are already meetings, supervision meetings that are being used by routine immunization and other programs. So we just integrated those already existing programs and shift the dynamics into COVID-19. So it was not a new approach. So we never need much training again for the health facilities and the community workers. We just needed just few training to add some components of COVID-19 in their micro planning. And we do not need to do a massive production of tools again, because they already have the micro planning tools, but we just needed to add that component of COVID-19 into those tools. So it was not resource intensive, and already district managers and community managers have already had a training on micro planning. So we do not go ahead doing a training on micro planning all over, because they're already trained. So we just included that component in it. So this is very effective, and it's not cost intense. And also to scale, it's very easy to scale. If governments choose to take this as a plan to scale, to advise their district managers and their regional managers to integrate this component of COVID-19 into micro planning, then it is very easy to do, because it will follow up the same structures and the same supervisions meeting done by routine immunization activities. but just an added component of COVID-19. So it is very feasible, it's not finance intense, and it can be done at very large levels, like national levels.
Thanks. That's really useful, Mbake. I'll give the last word, Dr. Faisal. We need to close, so maybe I'll just allow you a last sort of 30 seconds before we wrap up. And with apologies, I know we could keep going, but over to you for some reflections before we close.
No, thank you. I just wanted to share one thing about the cost, that the cost of community radios, these are really cheaper, and if you count cost with the other FM station or other mass media, comparing to that, cost for community radio is around 20%. So just wanted to share that one in the operational point. Thank you.
Thanks a lot, and thanks to all of you, Kennedy, Dr. Faisal, Bianca, Kali, and Joseph. A really rich discussion. There's more questions in the chat, so I hope you can continue to answer the Q&A. And I'll pass now to Deepa and Sylvia for some summary remarks. Over to you, Sylvia and Deepa. And thanks again to the presenters.
I'll go first and then I'll give you the floor, but thank you. Also want to take the opportunity to thank Danielle for today's work. So I just wanted to, first of all, say what a wonderful second day we had, great discussions, high level of energy and expertise. So this actually has been a pleasure to listen to all the speakers, but a pleasure to be really listening to seeing the interaction and the energy. What have we done today? Well, we'll try to unpack the topic of vaccine uptake acceleration under two different angles. They're different, but also pretty much interrelated, as I'm sure you would agree. The first session was really on effective strategies to counter rumors, to counter misinformation, information voids, really trying to give you all those examples of what might work for countering misinformation and providing people with the reliable, trustworthy information that they need when they need it. And so a lot of examples from across different parts of the world. And I would say here, three main points of main discussion issues that have emerged. First of all, the important topic of it's not just about technology, it's not just about the tool, but really about the strategies that are put in place that capitalize on those tools. So yes, tech matters, but it's really more how you are, putting technology tools into broader systems. So how you're working with the country leadership, with national vaccination efforts, with regional coordination groups, national immunization programs, and so on, to make sure that you're making a difference. A second point that we discussed is also how to select and involve the right trusted voices that are able to spread those kind of appropriate and key messages. And in this sense, really, we've talked about not only the importance of selecting them, but also making sure that they are equipped with the right information, with the right capacity, with the right knowledge, and keep that capacity building approach going on. And finally, a major point also on integration with other strategies. So yes, we need to talk about approaches to curb misinformation, but we need to kind of take them into the broader spectrum of how we're actually working in engaging communities more broadly, which is exactly what we have discussed in the second session led by Danielle on community engagement strategies to build trust in vaccines. And I think here really our main point was to try to provide you with different examples and different stories on how community engagement approaches can make a difference in vaccination efforts, particularly on that specific and critical dimension of gaining and earning and maintaining the trust with the communities that we want to work with. And different discussions here again, but if I want to sum up 3 main points for me, first of all, the importance of, I think that Danielle, you open it up and saying that when we're talking about community engagement, really we're talking about an art, a practice, a mix of different approaches. And I think that today's speakers really gave you that diversity of community engagement approaches, whether we were talking about community radio programs in Bangladesh, or community feedback mechanisms in vaccination campaign or DRC, or intergenerational dialogues in Tanzania, like different type of formats and approaches to help tailor messages and interventions for different audiences. A second main message is the importance of inclusive efforts and really being able to engage and represent communities, all members from the community. We heard particularly here the example of Cameroon and the micro-planning efforts that they've brought up in order to be able to reach all populations, and particularly vulnerable populations, and being able to use this approach to adapt SBCC to each and different group. And then a final point about integration, which is also where we started a bit the day, but the importance of integrating COVID-19 to routine immunization, to broader health interventions. And we heard here examples from DRC and Cameroon, and the fact that the reality is that for many communities, COVID-19 is not a priority anymore, but there are some good examples, there are some good benefits for that integration to happen. So these are some of the things that I heard. I heard much more than that, but I just wanted to give you a high-level recap. I thank you very much for your day and your participation, and I'll hand over to my colleague Deepa for closing us up. Deepa, over to you.
Thank you, Sylvia, and thank you, Daniele and Angus, of course. It has been such a privilege to be able to host this global event on vaccine demand, together with Ministry of Health Ethiopia and Government of Canada, in partnership with COVID-19 vaccine delivery partners. This event was successful because of many people's hard work and dedication for many weeks of preparations which went into it. So first of all, I would like to really start by thanking all the panelists who shared their rich and innovative yet practical country experiences with us through their high quality presentations. And I think we all would agree to the depth of the presentation and the quality. A big thanks to our wonderful facilitators and co-facilitators, Dan, Sheetal, Angus, Stacy, and Daniele. And thank you to all the participants who took time out of their busy schedule to be with us over the 2 years and interacted and engaged actively with us. We are still at 200 plus, which means that there's a lot of interest amongst all of us on this issue. Also, we cannot forget the support that we got from our interpreters, IT, and admin colleagues. So a big thanks, a huge thanks, in fact, to all of you. Some key takeaways for me, just summarizing the past 2 days. My colleagues Lisa and Sylvia have really gone into the details to pick up particular sessions, but I'll just talk about the few takeaways that I took from the sessions. Political commitment and leadership is key for a successful implementation of vaccine rollout. We would continue doing our demand-related work, but at the same time, we do need support from our political leaders as well as the service colleagues who are doing the implementation on the ground. We really need to prioritize the elderly, women, health workers, and the vulnerable groups. And this has come out very clearly across all the presentations that was done over the past 2 years. And as Daniele started in the beginning, that this is also a science. It's not just about, gone are the days when we talk about IEC material and radio only. It is a comprehensive science-based interventions we are talking about. We are talking about a mix of communication approaches and challenges which would motivate and also support the communities to take actions. Listening, of course, this has been the key theme all throughout, from the practitioners, from the communities, and also a lot of cheering for peer-to-peer learning, particularly for the work that Geneva Learning Foundation. And the reason why it was quoted was it provided an opportunity for people to learn from each other. Another thing which really came out very strongly is that it's about taking the services very closer to the communities, more outreach services. It's not just about whether we are working with communities also. It has to be a holistic approach. thinking out of the box. And I think these presentations really made our eyes open about how innovation and creativity can be done, yet in a very simple and practical ways. For example, the hackathon which came out was very interesting. Vaccine hesitancy, we all know that it has been a public health threat for a while, but the fact is that we need to build systems to track as well as address real-time all the rumors and misinformation which came out in today's thing. But finally, putting the communities at the center of everything we do. Let's understand the barriers that they're facing. What is the concerns and perceptions towards vaccine? And let's co-create local tailored solutions, which is key to the success of what we do. So I think the intention for us has been not just to showcase what is going on in different countries, but rather to learn from each other and see whether some of these can be replicated, some of these can be adapted in the local context. Every country is going to be very different, but I do hope that the learning has been useful for all of us, and we can think and reflect on whether we can apply some of these. Now, moving forward, at the end, I would really encourage all of us to think and reflect on what could be done, and please do provide us with any comments you may have. We will be producing a report to capture all the learnings, and that's going to take a bit of a time, but this is not just a one-off event. We started with the Geneva Learning Foundation's Teach to Reach session, where we heard from a lot of community voices, which has also informed this particular global event. But also in future, we will continue interacting with many of the colleagues on the ground. Some of these findings which have come out from the global event is also going to be fed into the Africa CDC's big meeting, which is going to come somewhere around end of July. So with those things, colleagues, really sincere, heartfelt thanks from all of us, from the Vaccine Confidence and Task Team, from all the partners and co-conveners of this event. Thank you so much. Have a great day, a wonderful day, evening or night, wherever you are. Thanks a lot.
Thank you, everybody. Bye-bye.
Thank you so much.